5 years? 10 years? Never. 10 years? Never. It takes 17 years for research to translate to practice. And this is not just a Kenyan statistic, it's a global number. So this forum is important. At least we get to see what is being done. Because if I wasn't called here today, I would not be aware about it at all. And we can look at these interventions and say, this is the country we can achieve. And I read through what you're proposing and the research that you did. It's feasible, isn't it? It's very feasible, it can be done. And we have a lot of research happening in youth mental health is happening in high-income countries. So this is important, and I hope you're able to publish this, because this is very important as evidence generation for Africa. And we also recognize that to improve the use of mental health, the mental health of young people, the solutions have to come from who? The youth themselves. There's a slogan which is used by the disability organizations. I don't know who knows it. Nothing for us. Youth should do that as well. We should support the youth to organize themselves, to mobilize, to advocate, and to implement programs which they lead themselves. Because me, I'm no longer a youth. So even if I'm the one sitting in that table and, making the decisions, I need to consult the youth organizations about what is it that they need. Maybe as a country, we feel like, youth, I think your biggest problem is this, we're going to solve it for you. And that's what has been happening, isn't it? A lot of decisions that we make, we don't have youth on the table. That's why I think this forum is very, very important. It's very key to youth leading the conversation. And we are committed to support, I have to say this as government, we are committed to support and work with various stakeholders to focus on mental health and psychosocial needs of young people. We need a mentally healthy population. Thank you very much.
Thank you so much, Daktari, for being with us today and for the very, very healthy insights. I don't know if we have questions. We can only take two. One, two, okay, one, two. Those are the two hands we saw. So Kim can help us. Those two questions for Daktari, and then we go to the next session. Okay.
Good morning.
Good morning.
My name is Evelyn Boa. Pleasure and thank you for the good work the government is doing to ensure that youth access mental health services within the country. Just to ask, currently we are in the CIDP plan. Is there anything that is in place like at the individual or the same? Thank you.
Which county?
Nairobi.
Would you like to respond to that or we get one?
Okay, good morning. My name is Domina. From Mind to Heart community-based organizations. My question goes, I'm a youth, and mental health in Kenya is very expensive. I'm talking from experience. What is the government doing to subsidize the price of the medication? Because sometimes you get to see a doctor, you're diagnosed, but you cannot purchase the medication. What's the government of Kenya doing about it?
So I will start with the first question. The CIDP, County Integrated Development Plan. That's it. So this question is specific for Kenya. But what I can say is that, health right now is evolved. So I know Nairobi County is doing a lot in terms of mental health. Stella is here. Stella can answer that question because she is the mental health focal person for Nairobi County.
Good morning, everyone. My name is Stella. I lead Nairobi County on mental health. Thanks for asking that. And I would say that for once in the history of development of CIDP, and for those who may not know, is that CIDP is a 5-year plan. And our government runs for 5 years. So we have a new government. So for the next 5 years, what are its priority in terms of development, programming, and all that? Kindly note that the CIDP is 2023 to 2027. because the government has come in, there's already a running financial year. So it will start in 2023 when we start a new financial year. What are we doing as Nairobi County? For the first time, and maybe for the organization that really supported us, we involved the youth, and most of you are part, some of you are part of it, where we involved you in public participation. Number one, we have a TWG, where the youth are part of it. Nairobi, we work more with the Youth Advisory Council and the other organizations like LVCT Plan International, who are part of the TWG. So we have a TWG. TWG is Technical Working Group. So we have Nairobi County Mental Health Technical Working Group that is all inclusive, both state and non-state actors, the youth as a center of it. So in that TWG, we told ourselves, what is our priority for mental health in Nairobi County for the next 5 years? So everyone, it was participatory, the top of our agenda is provision, increase in provision of services. So some of the things that we really push. So we came with these 5 things, and the youth, and I want to thank you, they were at the forefront to go to the public participation site, which we had 18 sites, and they presented this memoranda. Top on the list was employment of more psychologists, psychiatrists, or mental health care professionals. Number 2, you have said you have a problem with drug addiction. But we know apart from Madari, we don't have any other state-owned rehabilitation center. So what we're proposing is in the next financial 5 years to come, would we be having at least 3 drug rehabilitation centers in Nairobi? The other thing that is in the CIDP that is of interest is that we don't have a facility that where we admit our adolescents and children in terms of psychiatric care. We have psychiatric emergencies, for example, suicide, very suicidal cases, bipolar that have, and we don't have anywhere we can admit them. Apart from Madari, which again, I think is the time they're putting up a child and admission. So we have said that we want Mama Lucy and Magavi to have an inpatient psychiatric ward. And this should include a child-friendly inpatient. We have Pumwani. I know most people don't really have think about our pregnant women and those who have given birth, issues of perinatal mental health services. So we have proposed that Pumwani should have an inpatient for perinatal mental health services. So that even if that woman delivers or is going for ANC in any of the facilities, Pumwani should be our referral facility for inpatient services. The others are what we talked about, provision of psychotropics, but that one is not even going to wait for the CIDP. I'm already on it, and we are going to ensure that all our facilities, first in Nairobi, we have 27 facilities offering mental health services. What is of interest to you as the young people is our Ngaira Health Center next to Technical University, which we run a child-friendly space for 0 to 24 years, Monday to Friday. But on Thursdays, when we have a whole team of a psychiatrist, clinical psychologist, and a psychological team for assessments. So please, the youth, I always feel a bit, let down when every youth who comes to speak talks about inavailability of services in the room. At least we're doing something. We can share with you our referral network. In every sub-county, we have a facility that has a mental health practitioner. So kindly make use of our services. The beauty of it is that they're at no charge. We may have challenges of psychotropics, but at least you are able to see a psychologist or even a psychiatrist at no fee. So I think at the CIDP, we are on top of it, and we want to ensure, and again, we thank the governor because aspects of mental health was in his manifesto. So we have a lot of support. We even want to do a county-specific mental health bill. So we are very positive that in the next 5 years, it's going to be very transformative in terms of offering of mental health services to the Nairobians. So the youth, please come out, seek for these services, but as I conclude, your mental wellness is your responsibility. What are you doing? Even as you provide all these services, what are you doing as a young person to make sure that you become mentally resilient? The economy is becoming bad. What are you doing as a young person? Are you working out? Are you eating healthy? Are you staying positive? So at the end of the day, we want to pray back to you. We'll provide the services, but again, even if you see by the best psychiatrists, best psychotropics, you still have to own up your mental wellness. Thank you.
And this is a challenge, yes, we know that we face in a country because the cover for physical health is higher than that for mental health. But we have a new bill, the Mental Health Bill, the Mental Health Amendment Act 2022, which says it's a criminal offense to deny someone insurance coverage for mental health and deny them also access to mental health services. And it's very clear in the law. So right now we are working on implementing that law. And also we're having subsidized medication. If you've been to, we have 14 mental health units in this country. They have the medication, and we are bringing in newer drugs because mental health, we have the newer medication and the older generation medication. And a lot of youth will not want to take the older generation because of the side effects. So the newer generation now are available, like in Madara Hospital, at subsidized fee. So I think that's something that we're doing. We're also trying to increase financing for mental health. And I think that's something I discussed with George as well, is that last year we found that mental health cost the Kenyan economy 62 billion Kenyan shillings. That's a big, big number. And the cost is not on health. Health was 5% in the economy because we're absent from work because of mental health problems. We are coming to work because we have to show up or to school, but we have reduced productivity. So, and also premature mortality due to suicide. So that really showed that mental health needs a multi-sectoral approach. We can't just solve it as health alone. Yeah. There was a question here.
We allowed for
Is in regard to the Kenya mental health policy, one that runs up to 2030, 2030. One of the objectives or recommendation was to come up with an action plan. So how far have we gone? I know, of course, that we thank the government that we came up with the law, which was June 2022, just this year. But then I would be interested to know about that policy in terms of operationalizing, especially the fact that we envisioned up to 2030. Thank you.
Yeah, so on that, we have a mental health action plan. We launched it in 2021. So we have a 5-year plan, 2021 2025. And what is happening is that counties are coming up with their own plans. Kilifi has done it, Kajiado has done it. Nairobi County is in the process. Bungoma is also in the process, and Nyeri. So for us,
thank you so much, Daktari. Can we have another round of and a round of applause to all now, because the conversation got very domesticated towards the end. To the Kenyan participants who took part in the CIDPs and public participation. I see representation from Kiambu County. I see some young people from Nairobi. If I don't know you, I'm sorry. But we applaud you so much. Right now, we will still call into action. Please keep them accountable. Please keep them accountable. If your priorities are not captured in the same,
Ladies and gentlemen, good morning. Morning once more. So this is our service now. We are based in Kibera, salon that was formed in 2013 with an aim of empowering the community on different issues that affect them. And this is what we do in form of disseminating different messages. We use the dances, the poems, and the sticks. So enjoy.
The beautiful woman of Africa, with strong, white, density, which glitters in the sun as she smiles.
Singing a lullaby to my young ones as she watches the cookie pot on fire, getting ready.
Woman of Africa, who knows special being. Woman of Africa, mother of our homeland. Before the cock crows, she is already up.
Swinging her hip as she approaches from the street with the pot on her head, baby on her back, ready to begin her daily chores.
Of tilling the land, ready to dance. Woman of Africa, Max, special being.
Woman of Africa has endured many problems, shall bear
Her beauty, not a choice.
like a piece of burden, baby on the back, luggage on the head, subjected to death. No, no, no. And the offenders was free, forced to marry.
What she benefits, not to now. Education for a woman, luxury, not a necessity.
You educate a woman and you educate the nation.
Woman of you not, it should be.
Woman of Africa, special yet rejected. With the death of her husband, she is inherited.
If the inventor has AIDS, she inherits it too. Circumcision for women, another
While beating
almost alike, and not inhuman.
the woman of Africa, smile and bear this all.
Woman, I am not a special being.
Isekitela, 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 Echa, Cha, Echa, Isekitela, 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 Echa, Cha, Echa, Cha.
The wars in Africa have lost the women.
Sudan,
Congo,
Liberia.
Somalia have been torn.
She becomes a refugee, not for her sake, but her children.
When her husband goes to where sex and crime, she bears full responsibility to educate, feed, and clothe.
Oh, woman of Africa, you know, special being, woman of Africa is no longer in the dark, in politics.
She shines like any man.
In education,
On level.
in marriage, while honesty is now counted as no breaking.
Banning of circumcision has made her whole.
Equality in the places of work is just but normal, for no one is safe until all women are safe. For woman, woman, you are a special being.
Yes.
Aliega la mando, Anagia Firola, Nalamara Matikamando. Aliega la mando, Firola, Nalamara.
You know what the mental health feeling? If you feel like you have a lot of energy and you don't release it, what will happen? What will happen? You will
This guy was here, like, you. I saw a lot of energy. I don't know why you aren't waking up. What's
That's always Chinese.
you done? So we can put some. You have some Chinese dance there.
We can do that after today.
Yeah, sure.
So right about now, we'd like to give you strictly 15 minutes. It's now 10:58. You can take a bathroom break. We have water dispensers for the either sides of the room. We have 2 tea serving points right in front of the door. And towards the right, you will see white cups. That's your serving area, okay? Grab a cup of tea, coffee, whatever works for you. And please be seated by 11:13. 13 minutes past 11. Okay? If you see Kim walking around, please come back to the room. Okay? Thank you so much. Your 15 minutes start now.
And before you go, kindly remember, be your brother's keeper. And as much as you're going to be your brother's keeper, be a keeper of yourself, okay? That is mentally, physically, socially, and have fun, guys. So we see you after 2
minutes.
2 minutes.
Okay, bye. Enjoy tea. What time did you get to? Around 4.
Makes my heart warm.
The SCARS to STARS project is a project funded by USAID, of which the project's main aim is to seek interventions on how we can promote well-being for FGM activists and survivors.
So in this session, we were helping the girls to realize or to be self-aware of their emotions. Then after that, to reflect on the emotions that they have gone through and then to express. And this way, it gave the girls a lot of power to be in charge of their lives and to be able to say no, and also to be like the lead for the other girls so that they can educate the girls and reach out to as many as possible so that they will not undergo what the other girls have gone. I saw
My stepsisters go through the cuts. His youngest, class 4, got married at the same time. I was so privileged to be raised by a God-fearing grandmother since my mother was by then in school. Despite all that, my dad, they were so much rooted in the culture. I went through female genital mutilation when I was a very young girl. I wasn't consulted if you want to do it or you don't want to do it. Though I went through so much mentorships of FGM, like we used to, the FGM, like we used I remember World Vision used to come campaign against FGM, but I was so scared to tell my parents I cannot do that because I've seen all my sisters have gone through it, so I knew I'm not special.
Got an invitation to be able to come and reach out to these girls through yoga as an intervention, something that can at least help them achieve a bit of mental health, especially when it comes to this space, because survivors have been through a lot. And one of the things you want survivors to be thinking about is healing. And yoga is one of those go-tos, well-being tools that is available to people so that you're able at least to be able to find healing in a way. It's a bit, it's a bit harder than it seems, or as I say it, but it's one of the tools available to humanity, and it's been gaining a lot of prominence, in the past decade. Just be able to help, the girls, men, everybody really, just be able to find a better well-being.
I always say everything is all about the mind and mental health. Yeah, it's important because once a girl is cut, it's inaleta trauma kwake, and once the girl is not cut and she is in a society and other girls are cut, pia kuna trauma. So it's really important.
The reason for this project is we discovered that through our interventions, and our interventions are mainly focused on the protection aspect. But then the question was, what happens to our beneficiaries, the survivors, after the interventions? Are there any facilities for them to seek some sort of psychosocial health or psychosocial therapy? What happens to them after these interventions?
The mind is the driver, the body. And if the mind is not okay, then the body is not okay.
What are these stories I've been creating in my head? Why have I been giving them so much attention and energy? So the idea is now to bring them into a yoga space, help them calm down, just focusing on their breath in and out, and then they're able to find that bit of serenity and peace.
The Scars to Stars project is aimed at promoting well-being through psychosocial support, through providing a package, which will be the end result of the entire project, which can also be replicated by the people that, the participants would have trained, and these are the activists and survivors from youth-led organizations, and they will have to replicate what we've taught them to go to their respective wards and area of operation to do
Being a part of something that gives back to the community, being a part of something this big and this important in my community just makes my heart warm.
The Scars to Stars project is a project funded by USAID, of which the project's main aim is to seek interventions on how we can promote well-being for FGM activists and survivors.
So in this session, we were helping the girls to realize or to be self-aware of their emotions. Then after that, to reflect on the emotions that they have gone through, and then to express. And this way, it gave the girls a lot of power to be in charge of their lives and to be able to say no, and also to be like the lead for the other girls so that they can educate the girls and reach out to as many as possible so that they will not undergo what the other girls have gone.
I saw my stepsisters go through the cuts. His youngest, class 4, got married at the same time. I was so privileged to be raised by a God-fearing grandmother, since my mother was by then in school. Despite all that, my dad, they were so much rooted with the culture. I went through female genital mutilation when I was a very young girl. I wasn't consulted if you want to do it or if you don't want to do it. Though I went through so much mentorships of FGM, like we used I remember World Vision used to come campaign against FGM, but I was so scared to tell my parents I cannot do that because I've seen all my sisters have gone through it, so I knew I'm not special.
Got an invitation to be able to come and reach out to these girls through you.
Being a part of something that gives back to the community, being a part of something this big and this important in my community, this makes my heart warm.
The Scars to Scars project is a project funded by USAID, of which the projects
Being a part of something that gives back to the community, being a part
organization. And because in a few we are going to have their presentation and such. The South Africa, we also have two organizations. We have Rock of Hope in the building there in Kenya for the summit. They will still talk about what they do. Also, we have minutes are over. Well, this team is always very active. And so actually, clap for them. So when I say east, you say we meet south. Okay. When I say south, you say we meet east, okay? Out. Everyone? This is
South.
This is
South.
left. Yeah, clap for this guy. This guy is so this is
South.
and we have
East.
just come. Come and do something new. So this is easy. You have a problem. Okay, can just have you kindly clap for her. So remember, this is the East and South Africa Youth Mental Health Summit, and this is how we are going to do it. So this is
South.
this is South, and we have East. So this is South, and we have East. So you do the South one like this one, yeah. So you place it on top, yeah. Place it on top, yeah. So East. So let's start. Let's start from. Let's start. Let us start. Yeah. So East.
South.
East.
Next time, moment. Next time, moment. Yeah. Thank you. Good morning, everyone. So I don't want to be an ambassador, so excuse me, but I don't observe all. But to all the youth in the room, our distinguished guests, ladies, gentlemen, everyone who is here,
17 years, right? I don't even know if I'll be alive in 17 years. But so, thank you. So with implementation research, what we actually try to do is to make research more practical. We don't want to have this expansive, extensive, resource-intensive way of conducting research that just ends up sitting in a shelf or being forgotten, or by the time it's actually it's redundant. And so implementation research is a methodology, it's a participatory type of research where we are able to take what we learn and turn it into what we do. So it's think about it as a fast way of being able to turn learnings into action. And one of the reasons why we chose this method is because we know that, they say knowledge is power, research is power, and we want to be able to put power in the hands of young people, and so that they can be able to take charge of their own development, and not just their own development, but also to influence how development is done. And so through this approach, youth identify the issues that are pertinent to their localities, their areas. They develop their own learning goals, what it is they want to learn, and then as they find out, as they get some insights on that, they are able to adapt their programs. And our belief is that as they do that, they're going to be able to come up with effective ways of serving youth better. So Youth Excel works across diverse sectors. Today we are here to talk about mental health, and that's just one of the areas as Youth Excel we work in. The other thing we do, how we want to make sure that youth are able to influence agendas and at the same time that they're able to improve their programs, is through intergenerational dialogue. So one of the things I was really happy to hear when Stella, who's the Nairobi mental health focal point person, talked about how they engaged with young people, getting their views so that they can be able to make sure that goes into developing the mental health plan. And so similarly, as Youth Excel, we want to be able to give young people the platforms they need to talk with relevant stakeholders so that they can have a meaningful discussion. We often talk about, these are probably phrases that are familiar to you, giving youth decision-making, sit at the decision-making table, elevating youth voice. We hear that a lot, but a lot of the time it's just talk, right? And a lot of the time it's not action, it's tokenized. You come for an event, you're seen, but you're not really heard, like what the Wasani were talking about. And so what we want to do is to be able to make sure that we are able to have these to support meaningful discussions between decision makers who are often not young people and young people themselves. What we have today is just one example of a platform that we bring together to make sure that we can be able to share what young people are doing, and in the various capacities that you sit in here, whether you're in civil society organizations, whether you're donor partners, whether you're from the government, that in your various capacities, you're able to take this. As Dr. was telling us, it's good for us to see what is happening so that they can see how they can work with us. So that is one thing that we want to do, to promote meaningful collaboration, not tokenism, but meaningful collaboration between young people and decision makers, so that which they know, that youth-led development, meaning that, and I liked what was mentioned earlier, on the fact that we want young people to own their own. Actually, as a present Youth Excel, we are getting into our third year of operation, and we've already worked with close to 100 organizations. That sounds like a lot, but when you think about this from a global perspective, it's actually just a drop in the ocean. So the question is, the demand is always greater. Just to put things into perspective, for this grant competition on mental health, we were only going to support 4 to 5 organizations, and we got over 330 applications. So you can see there is a lot of interest in this field. And as those who have spoken before me have said, there is a lot of need to support the area of youth mental health. And so then, with the limited funds that we have, how can we make sure that what we are learning, what we are doing, spreads to other organizations? And that is why we focus on knowledge dissemination, knowledge mobilization. And so what that means is we work with open source, in the sense that all these learnings that you're going to hear about today, and in various other activities we engage in are made public. So these are public goods. As a present, we have about 100 public goods. So what you're seeing here is available in the public space. If you want to take it and adapt it, you're free to. And you're also free to consult on how to do that. So there's nothing that we are saying that this is our right, you cannot use this. We want these learnings to spread. We want young people's health to be supported better. And that can only happen when we collaborate and when we are free with sharing what it is that we are learning. So as much as we could not serve all the 330 plus organizations that applied for this grant, through sharing what it is that the 4 organizations have done, we hope that you're going to be able to have a greater reach. And so moving on to talk specifically about this grant competition. So this began, activities began in January. And so the theme for this grant competition was around youth mental health. Just to talk a little bit about how we came up with this topic. It's not that we just sat and said, what do we do today? I know, let's talk about youth mental health. We actually gathered youth and we asked them, what are some of the issues that are important to you? What do you think are some of the things that you want to be addressed? And so mental health came up as a very important topic. So the research that is supported by probably what has been quoted here by others who have spoken, is validated by what young people that we engaged with, we consulted, shared with us. Because of things, unemployment, COVID, and other reasons, this has become an issue that is at the front. I was happy to hear Dr. Nas tell us that there's funding for this, because I think now I'll be on her case. Because we feel like, honestly, there's not enough funding for some of these initiatives. And so with that said, the theme was around supporting or strengthening and vulnerable communities. So here today we have 4 organizations that you're working with. You've been talking about East meets South. I don't think I got that right, but in terms of the game we were doing. But like we got 4 organizations working on different things, but all on the area of youth mental health. So what you're going to hear today has been a culmination of research that has taken place over 7 to 9 months, iterative research, learning and adapting, and this is in the areas of working with youth mental health, youth in LGBTQI youth, and that is in Eswatini, working with youth living with HIV, and that is in Zambia, and at the same time also working, as you've probably seen from the exhibition outside, FGM survivors, and that is from Narok. And so today we are going to be hearing about why they went to conduct this research, what it is that they learned, and most importantly, I really urge this point, what you can do about it. It's usually nice to come for events, you have fun, interact with people, you network, but if we go and we don't leave you pondering with, we don't have an action item for us to leave at the end of the day, we may be where we started when we came here at around 9 in the morning. So my challenge to you is, and we're going to do this in the afternoon, is I want us to really think about what you're going to be hearing today, and think about, in my context, how I work, whether I work in an organization that supports youth mental health, whether I work in an NGO, I work in public sector, wherever you've come from, how do I take these learnings and adapt them? What is relevant to me? How can I, tap into this this wealth of data, this wealth of learnings, and how can I support that work? Where do I come in? Is there a flow of continuity? So we really want to foster collaborations. I was happy in the Mentimeter we did in the morning. There was a lot of I think one of the things that came up there is about collaboration. So this is, again, it's not a USAID effort alone. It's not a Ministry of Health effort alone. It will take all of us to combat the issue of youth mental health. And so that is what I'm hoping that by the end of today, we're going to be able to have achieved. So with that said, again, I welcome you to this event, and I please give your active listening to the 4 different organizations that are going to be presenting today. Thank you.
Thank you so much, Josephine. And we would like to. Thank you so much, Sylvia. So they are from, what they do, how they have been doing it, and then later on in the breakout sessions, we will have a question and answer session. So if you have any questions during their presentation, kindly give them time to run through it and finish. We will ask questions after. Is that clear? Ladies and gentlemen, Rock of Hope. Okay, thank you, DJ. Kim would like to borrow your microphone. And over to you, Rock of Hope.
Thank you. Good, is it still morning? Yes. Good morning, ladies and gentlemen. Yes. My name is Sanel Sibia, Executive Director of the Corporate Swati. We are an LGBTI founded and LGBTI-led organization in Eswatini, dealing on a broad spectrum of issues that just basically aim to better the lives of LGBTI people in the Kingdom of Eswatini. I keep losing my screen. Like I don't have the screen right in front of me.
Let's help you with that.
There is no input signal. There we are. Thank you. So I'm going to take us through the very first bit of the presentation. I don't know if my pointer to move. So I'll take us through the first bit of the presentation, and then my colleague here, Zolisha Shamini, will take us through the other bits of the presentation. So when we started this work, we wanted to explore the different modalities of providing psychosocial support services to LGBTI youth in Eswatini. So we started this journey in January to present. That's why we're closing now. May I have the next slide? So there is just a presentation of who we are. I am Sanel Sbia, Executive Director at the Rococo Eswatini. So I am actually a gender scholar as well, and I've been in the LGBT movement and pushing forward the movement, I think, for over the past 12 years. I'm contemplating retirement. So with me here is Zolisha Damini, a proponent of human rights, and basically she is one of the people we work with to ensure that we are inclusive and we're diverse in the work that we do. I mean, you would think because we serve LGBT people, we would know what inclusivity and diversity means, but at times we falter and drop the ball, so we count on her being and her astute thinking to actually keep us on track and make sure that we really are diverse in the way that we work. And we were actually very shocked, when we started this work where we had to do the IGPR. We never thought of that because we thought now we're dealing with IGPR. So basically everything we do should be gender aware. And then when you do that, you go through that process, you learn that, our LGBTI focus somehow is discriminatory, and we never really get to understand the gender dynamics within the LGBTI persons themselves. So that process was very much helpful, and we move on forward with that. So next slide, please. So who we are is the Rococo Eswatini. So our mission as the Rococo is we just endeavor to build a society in Eswatini that is free from stigma, discrimination, and oppression of gay, lesbian, bisexual, and transgender people. And this includes prisoners and sex workers who fall within the genres of LGBTI persons, Then our vision is we endeavor to build a society in which every LGBTIQ plus individual attains full health rights, freedoms to be themselves, and social well-being, resulting in high quality of life without any prejudice. So the work that we do covers these areas. We work with law enforcement and human rights. We maximize, where we work with the LGBTI persons themselves to activate their agency. We also work within health to raise awareness and also to ensure that we work sustainably within health to make sure that when the funds are gone, they still remain and we still provide services to our people. We do global outreach. where we work through the UPR processes. We also do social support and empowerment and charity work. So that in a nutshell would be the work of hope as it is presently. Next slide, please. So basically how we work, health advocacy, we work with ensuring just keep on so the work that we work with health advocacy, that's where we work with healthcare providers themselves, including social workers, to make sure that they're able to provide services in an adequate manner to the LGBT community. We also do the sustainable health financing under this component, and we also do advocate for mental health and its inclusion within the broader HIV work. I mean, the current plight of LGBT persons in the region and across the globe is that the governments tend to be accepting of LGBT people within health and actually within the key population landscape. So we also try to work within that landscape to balance and make sure that LGBT issues are prominent. And then we also do religious advocacy. Eswatini is a highly religious country. About 99% of the country is actually Christian, so we find there's a lot of power within that sector. If you want to advocate for social change and broader acceptance of LGBT persons, you cannot leave the religious sector out of it. We also do community engagement. That's where we work with communities at grassroots to make sure that LGBT persons have space within their communities to work and to live. We also do legal advocacy. That's where we work with the police and the offices and other offices within the human rights commission. We work with the justice ministry. We also do coalition building, so we are very much in the lead and making sure that LGBT persons are able to actually form a force and a movement that advocates for their social change. And then we also do work around comprehensive sexuality education. So it's one of the avenues we use to make sure that people get educated about sexuality. So now, coming closer to the work that we've been doing with IREX. So we started with a bit of a background there. You will see that's background on the related work. So one of the things that we do at Local Hope is we try to create the evidence of why the governments and other duty bearers should actually engage and provide services to LGBT persons. So one of the core things we do is actually research, because when we started, we were told that there is no research, there's nothing to help us understand the plight of LGBT persons. Why should we even start talking about people we do not know? They don't even exist. So we do a lot of research. In 2019, we did a study working with 3 regional partners, and we were just basically assessing the mental health well-being of LGBT persons in the region and key populations. So that study where we had 109 participants, and a striking finding there was 48% of those respondents revealed that were actually diagnosed with depression clinically, and 52% of those were diagnosed with anxiety. We also found through other studies that intimate partner violence, stigma, discrimination, and economic risk were reported high amongst LGBTI persons. So when we got the opportunity to come into the Youth Excel and to even bid or apply for the Youth Excel funding, we planned an implementation science research approach to really just explore the modalities for providing psychosocial support services to LGBTI persons and to use those to advocate for the inclusion. Our first thinking was to advocate for inclusion within the broader HIV type of framework, because that's where a lot of key population issues, including LGBT issues, get pushed. So we wanted to evaluate those different and study the effectiveness and the efficiency of the different modalities for providing mental health services to LGBTI youth in Eswatini. With those, we expected to actually have more people seek, more LGBTI persons seek psychosocial support services. We also endeavored to reduce the prevalence of depression and anxiety amongst the youth, amongst other objectives. And then we also hope that when we're done, we'll have a much more stronger mental health and psychosocial response system in the Kingdom of Eswatini. Okay, now start moving. think I have moved so much. Okay, the meaning is, I think I've already gone through those. We wanted to find the best way and strengthen existing more modalities for providing psychosocial support and violence response in Eswatini. And we also wanted to understand the impact of life skills on mental health outcomes of the LGBT youth in Eswatini. Mainly because we know that Eswatini unemployment is very high. So we suspected that the economy would have something to do with our mental health disorders in the kingdom. So here's the methodology. Basically, the way we structured the research was we started with a baseline of 300 participants. We used the cage to monitor substance abuse. We used the cage tool. We used the opioid risk tool. We used the patient health 9 questionnaire and the generalized anxiety disorder number 7 as the initial and the baseline. And then from there, we enrolled people into the project. We enrolled our respondents into the project, which is something we call the treatments. So when they take the treatment over 7 months or 5 months, we give them sessions, and then that's when we collect data. So in a way, it's more like we're going to have that longitudinal data. So we offer the services, and then every time the person came for services, we had to take them through the screening using the very same PHQ-9 and the GADQ-7, just to see whether they were improving or regressing with regards to anxiety and depression. And then now we then had to do a report, which was the final stage. So the interventions that we offered, or the treatments in this case, that was your counseling sessions and the life skills sessions. So we were able to monitor all those through the process. So the sampling approach, when we started, we used snowballing, where we relied on members that we know are part of the digital community, and then we would then use them to find the other, and then the other leads us to the next until we reached our sample of 300. That's what we started with. And then overall, what we then had was a baseline of 300. And then we had respondents that stayed through the project and key informants. That was 134, but my colleague will go into more details on that. And then we also did our surveys. Most of our tools were actually electronic, so we did that to ensure that we preserve the privacy and of our respondents, because we didn't want the information leaking around, so it just went straight to the office, and then the tablet, the data collection device itself never contained anything. And then we had about 60 key informant interviews, which included, amongst others, the data community, social work departments, the Ministry of Health, different departments within there, and business sector. Then we also had 27 focused group discussions. So that, in a nutshell, ladies and gentlemen, is how we structured the work. So I will now hand it over to my colleague to take us through the results. Thank you.
Hi everyone. How are you today? Very fine, and I'm glad to be here in Kenya. It's my first time. I was telling one of the brand partners that it was my first time on an airplane. So I'm very happy. Okay, I am Zwelisha Zamini, and I am the M&E at the Rock of Hope. So I am here to share with you our findings for the research providing psychosocial support and mental health to the LGBTI youth in Eswatini. So here I have demographics by the research methodology. In early February this year, we conducted the IRGP analysis to inform gender dynamics on the project that we're trying to implement. So the key informants here were the many people. We had civil society organizations, we had youth organizations, we even went to the private sector, the public sector, and even academia, just to find out what is really happening in Eswatini and get a clear picture before we start this whole process. We also had the Research to Change, which was influenced by our LGBTI youths who are beneficiaries of the program, the peer counselors, the social workers, and even the public social workers, because we are trying to create a violence response system in Eswatini where everyone is capable of helping and giving mental health and support to whoever needs it. Below, you will see our research participants. So in the end, we have 100 participants, 60 of which received only counseling support, and 40 participants received a combination of counseling support and a life skills education. So this life skills education that we're providing, we didn't give it to everyone because we wanted to see that life skills as an external factor, will it contribute to decreasing depression and anxiety within the youth, especially in Eswatini because we also have a very high unemployment rate and most of our population is made up of the youth. So it was very important to us to see that if we add this component of life skills, will it improve mental well-being of the youth? So the total 100 participants that we have here are 41 bisexual participants, 32 gay participants, 21 lesbian participants, and only 6 transgender participants. Okay, I see what my colleague was saying. So I thought it was just okay. So yes, the initial target was 300 LGBTI youths. We managed to reach and collect baseline data of 327 youths, but we had a high dropout rate of about 69%, meaning 227 youths decided to drop out of our program, leaving us with only 100 youths to work with through the implementation of the project. So what are the reasons for the high dropout rate? Participants were unwilling to share their personal information to peer counselors. A lot of people don't know that they need help, even if they do. So they felt like, I'm not going to share, I don't know this person, why am I going to share my life story with them, and where does it get me? Another reason for the dropout was a disinterest in the counseling sessions themselves. As I said, they did not feel like they needed counseling sessions. And there was a slight delay in the implementation. And this caused us to lose some of our participants. So that pictogram that we have here shows that out of the 227 participants, we collected baseline data. Now, you'll forgive me. I was telling my colleagues here that I forgot my glasses and their numbers there, so I have to read. So 40.5% were diagnosed as clinically depressed and anxious of those participants who left us in the program. And then we have 59.5% who exhibited minimal and mild cases of depression. So from the 227 participants, we do see that a large proportion of the number who left do need counseling sessions. They do need mental health interventions. But however, they did drop out of the program. Of the 100 participants who remained, we had 71% who were diagnosed as clinically depressed, and 21% exhibited symptoms and signs of minimal and mild cases of depression. This is more on the participant demographics. Here I have disaggregated our participants according to their constituency and their sexual orientation and gender identity, SOGI. I hope you remember that from now on, because I'll be using that whole term a lot. So it's sexual orientation and gender identity and expression. We call it SOGI for short. So a constituency in our country is like a very small county. These are a group of people with shared interests and political opinions. So we have, I did something very bad. Technical advisor, please help me. Okay, let me explain on our constituencies before. So we have 3 different constituencies that we looked at. We looked at a rural-urban constituency, a somewhat urban constituency, and a very popular urban constituency. So what we found in these 3 different constituencies is that they are not the same. They have different beliefs, different views on LGBTI. And actually, in the rural constituency, we found the least number of participants in the LGBTI youths. Is this due to, thank you, technical advisors. Is this due to a lack of safe space? Possibly, yes. And then in the Kwaluseni community or constituency, we found the second largest number of participants there. And with the Manzini North, where people are free and it's very urban, close to town, we have a lot of LGBTI there who are very free to express themselves in the Kingdom of Tsuki. So with our participants, the transgender community was the least in our findings. Well, this is largely due to because the transgender community in Eswatini is about 103 people at the moment, and they are very scattered, and there's a lot of discrimination and stigma towards transgender people more than the other participants more than the other groups in LGBTI. They face the most discrimination and the most stigma. So our focus group that we're targeting for the Youth Excel activities were from 21 to 25 years. We saw that those who are between the ages of 21 to 25, they demanded more of the psychosocial support. And the demand fell as the age groups rose to 35. And then I have in yellow other age groups, which were not the target population, but they did come out because this program was well advertised on our social media pages. So they did come out and say they do want this. Can they please get counseling sessions? Even though they were not the focus group, we still gave the counseling sessions to them. So this is a further disaggregation of our depression among the participants. In screen 1, which is an assessment 1, our first assessment of the participants after counseling sessions, we found that around 30% show signs and symptoms of mental depression, while a large 70% show signs of severe depression. Throughout the counseling and life skill sessions, this did transcend to now a minimal depression among participants of over 80%, while the severe depression is now lower than 20%. But you will notice that it is not at 0, because mental health is a process. It's not a 5-month thing, it's not a 7-month thing. So these youths do go back to toxic environments where they do face discrimination, stigma over and over again. So this does need continual support. More key findings on our counseling sessions. We wanted to compare whether youth would prefer physical sessions with their peer counselors or psychosocial support givers, or if they would prefer from the comfort of their home and privacy online sessions. However, youth wanted to actually sit down with someone. So 73% of our participants opted to sit down with a peer counselor or an LGBTI social worker, even some of them the public social workers. So they do want physical interventions. All right, I'm warning you on time. I'll try and keep it short. One of the LGBTI stated the reason for being within physical sessions as the online session is weird. Maybe when I'm used to my peer counselor or there's an emergency, that's when I can use it. So while conducting research, we asked the youth, what is preventing you from seeking psychosocial support in the country right now? We have free psychosocial support services in the country. It doesn't charge a cent. What is stopping you from going there? They cited fear of discrimination. They are afraid. So we are facing stigma towards mental health itself, and we are facing stigma towards the LGBTI. So they are facing a whole lot of stigmas. So 5% of the participants did seek psychosocial support from public social workers, but they were not happy there because they found themselves seeing various social workers for the same case. There were no follow-up calls. They complained of disorder, and that was the last time they went there. So we do need to strengthen our public health sector. We found unemployment and intimacy partner violence to be one of the standing out problems and mental distressors of the LGBTI youths. With the life skills, we offered entrepreneurship, personal finance, and business management. So with the 100 participants we had, we told them about this program. We told them that to apply, you need to write an essay and say what you want to learn and why you want to learn. So about 50 or so participants handed in their essays, and we chose 40. Offering entrepreneurship to 17 participants. So with entrepreneurship, we just teach them the basic skills of what it takes to become an entrepreneur, how to empower yourself, how to actually take the lead and start your own business. With personal finance, we taught them how to invest their money wisely and save as much as possible. Lastly, with business management, that was how to write standing CVs and resume letters that stand out and give you a job offer when you see one available, even though they're so rare. So with our life skills, I have there in green, those are the people who did receive both life skills and counseling sessions. And in yellow, I have people who only received counseling sessions. As you can see on the slide, there's a fluctuation in those who received only counseling sessions. But with life skills as an added external factor, there's a straight line, a straight gradient, those of you who do mathematics, of a decrease in their depression that they face. So below there, I have a finding that 5 out of the 40 participants actually went on to start their own businesses, 2 transgender people, and 3 people, 2 who identify as gay, and 1 lesbian woman got jobs post this implementation. Our research adaptations. The mental health screening tool was long. My colleague here mentioned 4 types of screening tools for mental health, but we only used 2 because while following up with participants, we saw that it was too long for them, and so we decided to cut it short to only evaluate depression and anxiety. So we had a few female participants in the program, and we hired 2 more female peer counselors. This increased the reach of female participants. We also incorporated a motivational component to the life skills to encourage them to finish their life skills. And then another adaptation is that we did shift from our peer counselors who were outreach workers and focused under the HIV program because they couldn't juggle the work and were the reason for delay in our implementation of the program because the HIV work is very demanding. We do not want to mix mental health with HIV. And before I reach to the conclusions, I'm sorry, timekeeper, just kidding. Okay, before I reach to the conclusions, I just want to say that thank you to the IREX team because through the IREX and USAID, we were called to national radio for the first time to talk about LGBTI cases and mental health across the youth. That has never happened in Swaziland. Next one. Okay, the conclusions from the research. You were very smart people, just run through them. So the LGBTI youth does prefer physical sessions in LGBTI-friendly spaces. Participants who receive life skills, this shows that life skills are necessary, and we want stakeholders to adopt this. We need structure in the public social sector. If we are going to seek help from them, they should be organized. And lastly, fear of stigma and discrimination. What can we do about it? Okay, to the donors in the room, we urge you to please provide more opportunities, more funds for the LGBTI. Take into account the vulnerabilities that they face. To implement this in your programs. 2 governments, abolish laws. Africa is very known for laws contribute to stigma and discrimination against the LGBTI people. Let's abolish those laws. Let's incorporate these people into our lives. They are part of us. We are one. Let there be no divide. And then to ministries of health, apply gender affirming and diverse policies into mental health. Let all mental staff, be trained in solving sexual orientation, gender identity, and expression. Let's leave no one behind. And then to us, civil society organizations, let's raise mental health awareness. Let us create a forum for the LGBTI people, and other minority groups. And then to the policymakers, let us remove mental health. Okay, she's coming for me, guys. Let us remove mental health from the HIV program. Mental health is just as important as physical health. We need to separate the two. We cannot mix it because they are both huge fights. And last but not least, we have our knowledge products where you'll find much more information than what I'm giving you. Hope to see you soon in the focus group discussions.
So a round of applause to Rock of Hope. So its passion and focus and transformation was an organization. I guess Rock of Hope can well define that, isn't it? So I know you guys have a lot of questions, but just hold them and we'll have that session during the breakout session. So next, presentation.
Ladies and gentlemen, welcome Tribe Guru from Uganda. Keep clapping, keep clapping, keep clapping. Keep clapping until they get to the stage.
Yeah, that's a new style of dance. Yeah. Let's shake your elbows. Shake your shoulder. Wow.
Thank you so much, Tribe Guru. We will exit them from stage with the same song.
This looks energetic. Wow. Welcome.
Hello. Good afternoon. This is Thrive Gulu. We are a local NGO of work. Our next investment is in supporting and working towards prevention and response to violence against women and girls and youth.
In achieving land, dance is a very strong mobilization tool. Dance in itself brings
that clip, we'll have it in the breakout sessions. For now, let us focus on the implementation research results. Okay, so when they're putting up, the song we came with is a song by one of the youth who, the category, the team that we call youth with lived experiences of mental health. And he's a local artist, and the song is Yole. So it's giving youth hope that, you know, the sky is the limit. They can still achieve, even with all the struggles that they can grow up with in their family backgrounds, in interruptions in education, and in all that it takes for someone to grow and mature. Thrive Gulu, I will continue. Thrive Gulu is a women's led. Thrive Gulu is a women's led organization and a youth serving organization. We have been operational in northern Uganda in 5 districts. Our vision is a northern Uganda in which everybody is treated with dignity, live in a safe environment, and are able to contribute to the good of their own communities. Our programs are focused on 2 broad pillars. Our biggest fish is investments into mental health and sexual support. Our next big fish is empowering communities and individuals so that they can flourish. The word thrive is not an acronym. It is from a survivor to a thriver. We want to see those who have survived and are living now to thrive, to flourish, to go beyond the skies and achieve in life. We invest in adult and youth literacy heavily. We invest in gender-based violence prevention. In the last 5 years, we started investment in the humanitarian aid to support our brothers and sisters from South Sudan who are refugees in northern Uganda. And we are in Palabeg, a refugee settlement, supporting response and prevention of violence against women and girls, as well as providing our mental health and sexual support. We are operational in 5 districts in northern Uganda. We work with other stakeholders and government officials. We work with the survivors themselves, and we support teenage mothers and fathers to re-enroll in formal schooling. Perhaps most of us have followed the 20 years war that was in northern Uganda. And of course, the effects continues to be lived. In the earlier presentation, somebody talked about the intergenerational trauma, which is still very strong in northern Uganda. And the few resources and studies around indicates up to 97.7% of people live with post-traumatic stress disorder. Half of the youth have reported moderate to severe depression and anxiety, and nearly 25% of the youth have considered or attempted suicide. And these are not small, these are huge statistics. And our implementation research will actually compound on this. From the different grants that Thrive Kudu has received, we were blessed to receive a fund from Comic Relief under the theme Ahead of the Games, Sports for Mental Health. And guess what? For Thrive Kudu, we chose dance as the sports. And just this morning, we saw what dance in mental health, what results we could get out of it. And those results, Dennis will read them for us. So we chose dance, basically because dance has very powerful healing effects, but also that we can use it across for children, for young people, for adults, and we can use it across all cultures and all traditions. Am I lying? So we chose dance for those reasons, and probably that was one of the reasons that made our proposal go through in that competition. So we decided to integrate dance and movement with the traditional mental health therapeutic approach that we've been using. And in this case, we chose the 12 weeks structured treatment, mental health treatment approach that is commonly used by Center for Victims of Torture. So we decided to integrate dance into that 12-week. So we then had to develop a new curriculum with the funding from Comic Relief, and we sought support from a partner called Dance for Life. We're actually doing dance for reproductive health with young people. We decided that the curriculum should be peer-led, so it is the youth who supported us in designing how the curriculum should look, and we only paid attention to the technical aspects of the mental health treatment approaches that needed to be included. We've used the curriculum for both adults and youth,
We've used it for both communities in rural and urban setting. We've also integrated gender and disability inclusion. Why did we choose the implementation research? When we saw the call for this application by IREX, we felt this was an opportunity for Thrive to learn more on this new innovation in integrating dance into our traditional mental health. And we thought this was a perfect opportunity so that as we complete the 2 years pilot, then we have better documentation, better research work, better results to present as a whole. So that is why we chose how the implementation research, we made a decision to integrate it into an existing program that was going on. We focused on purpose to evaluate the manual because this is the first of its kind, but also we wanted to focus on how the use of peer leaders, the effect of using the peer leaders in this approach and in providing mental health to the young people. And then we also wanted to look at the overall project outcomes. And I'm very happy that with funding from Youth Excel, IREX, and USAID, we were able to document significant learnings that we will share today. Our goal in this project is strengthening mental health and sexual support for marginalized and vulnerable youth in northern Uganda. The Dance Plus Therapy, just a brief, the Dance Plus Therapy project is a group counseling approach. I've already talked about it, and it is integrated to effect measurable reduction in depression, anxiety, stress, and suicidal thought for both age and gender inclusive, urban and rural. And the curriculum is built on the 3 stages of Judy Ammann's trauma recovery stages. There is the safety and stabilization stage, remembrance and mourning, reconnecting to self and others. So that is the 12-week trauma treatment approach where we integrated dance. In that 12th week, we also integrated the social-emotional learning, the 5 core competencies. I might be going technical, but just for us to know where some of these things are coming from. So the 5 core competencies are self-awareness, responsible decision-making, relationship skills, social awareness, and self-management. And already you can see that these core competencies are very, very vital for young people. What do we do in the project? So in the project, like any other project, we do screening for direct beneficiaries. So we do youth screening using the standard tools that are used, global standard tools that are used, the Patient Health Questionnaire 9, the Urban Trauma Questionnaire, the Generalized Anxiety and Disorder 7, and the SAFE Protocol for Suicide. Now, youth or individuals with moderate to severe mental health challenges are then enrolled into the 12 weeks curriculum, each of the group having a range of 10 to 15 members in each group, so that the group is small because there are critical aspects of confidentiality for group members to commit. There are also aspects of individuals sharing their personal stories in the groups. So the groups are smaller and we maintain them small. In the groups, members are able to learn signs and symptoms of mental health, causes, prevention, and available service points where they can seek support. They also learn skills of anger management, interpersonal skills, and they're also engaged in mindfulness activities. We have a range of mindfulness activities that we use, breathing activities, yoga. We have all those mindful activities that we use. The youth in their groups also share experiences during group sessions, especially in sessions 6, 7, and 8, where we are
taking them back to remembering and mourning the losses that they've gone through in life. So in that stage, they are able to share, and then we have backup from our professional counselors within their groups. Again, in that group of 10 to 15, they again break up into smaller groups, also to enforce confidentiality, but also to make it smaller so that a counselor is there to attend to them at individual levels, even when they're sharing on the group level. After the 12 weeks, we do post-assessment using the same tools. And after the post-assessment, for individuals and youth who have not achieved the healing to the level we want, we continue to provide case management for them through our professional counselors, where the youth might need additional support of mental health medication. We work very closely with the psychiatric teams in our health facilities across. Wherever we go, the psychiatric teams are like our first allies that we need to find and talk to and make working easy with them. So then we support to provide both the talk therapy and then the mental health medication, where a client needs that. When they complete their groups, then they use the opportunity, the learnings, to go and provide awareness in their own communities. So they go to their communities, to their churches, to their schools, to their marketplaces, and usually it's not so much with our support as an organization, but their own work that they continue to do. And all this, we want to achieve improved mental health well-being for young people as the next generation and the next parents and the next leaders that we want to see. I want to stop here and allow Dennis to take us through the implementation research and the results that we were able to achieve. Thank you.
Thank you, Dora. Greetings, everyone. My name is Okilo Dennis Lokoroma. I support the monitoring and evaluation functions at Thrive Gulu. Building on Dora's presentation, as Thrive Gulu, our implementation research project focused on two cardinal learning goals. One, to measure the effectiveness of the 12 weeks dance plus therapy training manual by documenting best practices and identifying areas of improvement. Two, to ascertain how the project changes youth mental health and their overall quality of life by documenting the impact of the project on the well-being of youth mental health. In our research approach, we used simple random sampling, a probability sampling approach where units are randomly selected from a population to constitute a sample. We also use convenience sampling approach, a non-probability sampling method where units are extracted from a population deliberately for purpose of inclusion or easy access of respondents. In our research, we were able to reach out to 149 youths who were our respondents, 24 male, 125 female from 11 youth groups. 75 youths participated in our survey, 149 all the youth beneficiaries were engaged in one-on-one interviews. We also had 4 focus group discussion sessions with our youth participants. Very delighted to share with you key findings. Depression. Using our PHQ-9 tool at both pre-assessment and post-assessment, At pre-assessment, 94% of the youths presented with moderate to severe signs and symptoms of depression. But after the 12 weeks of dance plus therapy intervention, that is at post-assessment, the youths, 87% presented with 0 to minimal signs and symptoms of depression. The 13% continue to receive case management support from Thrive Bulu team. Our case management support is a wide package of support that incorporates counseling, referrals, including direct support such as medical support to our beneficiaries. Post-traumatic stress disorders. Here we use the Harvard Trauma Questionnaire tool, both at pre-assessment and at post-assessment. At pre-assessment, 81% of the youths presented with moderate to severe signs and symptoms of trauma. But after the 12 weeks of dance plus therapy intervention at post-assessment, 99% reported 0 to minimal signs and symptoms of trauma. The 1% continued to receive case management support from Thrive Bulu staff. Anxiety. Here we use the generalized anxiety disorder tool, both at pre-assessment and at post-assessment. At pre-assessment, 95% of the youths presented moderate to severe signs and symptoms of anxiety, but after the 12 weeks of dance plus therapy intervention, at post-assessment, 86% reported 0 to minimal signs and symptoms. The 14% continued to receive case management support for total healing. Suicide. At pre-assessment, 6 youths presented with signs and symptoms of suicidal thoughts. But after the 12 weeks of dance plus therapy intervention at post-assessment, all the 6 have fully recovered with no signs and symptoms of suicide. Here we use the safety protocol tool both at pre-assessment and at post-assessment. And the pre-assessment tool was administered to all the 149 youths, but out of the 149, only 6 presented with suicidal tendencies. Dance. Youths presented to us that dance to them is a tool for celebration. It's a celebration tool. They also demonstrated that dance is a fitness tool. We have seen many of them exercising using dance sessions, and they also mentioned that to them, dance is a stress management tool. When they are stressed, they feel, when they put on music and they start dancing, they feel a little better. So in this dance plus therapy program, dance component came out very profoundly as a very important tool that the youth appreciated. They come celebrating in the dancing while also receiving the treatment during the dance plus therapy sessions. 80% of the youths actually did not know they had mental health conditions prior to enrollment in the dance plus therapy program. At the end of every 12 weeks of the dance plus therapy intervention, we do what we call the client satisfaction survey. And results show that 92% of the 149 youth participants in the program have loved the program. They are very well pleased with how the program was being conducted. We also found out that rural youths actually are presenting higher levels of mental health challenges in terms of the signs and symptoms compared to their counterparts in the urban centers. This was attributed to factors such as high level of school dropout in the rural setting compared to the urban, severe effect of the Lord's resistance, army war in the rural setting versus the effect in the urban setting, but also the lack of youth-friendly services in the rural areas. Interactive approaches. The youth demonstrated and expressed likeness for innovative and creative ways of sharing information on mental health. They were very bold during the radio talk shows and TV talk shows where the youths were at the forefront to disseminate information on mental health. They were also very excited with the interactive t-shirts that has key messages that provides information to the world or in their communities on mental health. Those that had smartphones and were able to access the internet were also very excited with the Dance Plus Therapy Youth page, which has information on youth mental health, as in the link that you're seeing. Male inclusion. During the implementation of the program, we registered low inclusion of male counterparts in this program as compared to the female counterparts, despite the improvements registered in the course of the implementation research. At baseline, we had 2 male as part of the Dance Plus Therapy group, but at endline, we were able to register 24 males against the 125. Males generally present a poor health-seeking behavior, and yet, according to Makerere University Health Science Report, the male to female suicide completion rate in Uganda is 3-1. Disability inclusion. At baseline, we had no youth participants in the program with disability, but at the end of the project, as we wind groups and enroll new ones, we were able to bring on board 8 youths with disabilities as part and parcel of the Dance Plus Therapy program. Skilling. Youths also expressed overwhelming likeness and love for skilling enterprises, such as vocational trainings and startup capital, to be integrated in the different services that service providers are extending to them. Just to appreciate feedback from our direct beneficiaries, here are some of the notable quotes. Flavia, a D+ team member, said, I had thoughts of committing suicide because of the situation I was going through, but when I joined the D+C group, I got counseling and I was supported by the other group members. I learned that everyone has challenges, but how you react is what makes you a victor in life. At a group level, a president of one of the youth groups called Onenchan said, the Dance Plus Therapy program brought us together as a team. It taught us how to control and manage anger. It empowered members to cope with hard situations and choose positive coping mechanisms. We learned coping skills such as breathing techniques, power pose, and dance. Then also at leadership level, a peer D+C leader from one of the youth groups said, the Dance Plus Therapy program has offered me the opportunity to nurture my leadership and mentorship skills. I used to fear speaking before a group, but now I am very confident and can address a crowd of people without fear. I am proud that I can give back to my community. Conclusion. Dance Plus Therapy program with evidence is leading to measurable reduction in signs and symptoms of depression, trauma, anxiety, and suicidal tendencies. The Dance Plus Therapy manual is effective, though some of the sections in the curriculum needs review to achieve maximum results, such as translation from English to local dialect. Disability mapping, we need to do more on statistics and data around disability to improve our programming at planning, advocacy, and budgeting level for persons with disability. Youth peer leaders, improvement and building leadership and facilitation skills for peer D+D leaders, and this was their confession in terms of how the program impacted them. Recommendation for different actors. To youth-led and youth-serving organizations, we need to be more intentional and inclusive of youths with disability in mental health programming, with budgets supporting provision of assistive devices, but also supporting holistic youth programming services to ensure that the youths can benefit from all corners, including mental health, education, IT, and most importantly, skilling enterprises being integrated in this core program. Because one of the core stresses that we generated from the youth was that poverty is a major factor of these mental health challenges. To policymakers and youth leaders, we need to do more on generating data on disability to support disability inclusion, and also planning, budgeting, and advocacy. All stakeholders, to all of us who are here, we need to think more and better when it comes to inclusion and gender parity. We need to be more inclusive in terms of all genders to participate in programming at all levels. To thrive Gulu, we need to improve on our manual to make it more simplified, especially for the benefit of the youth based on the learnings that we have identified and areas that we need to improve. We need to take that into account. Then to the donors, we need to prioritize funding for our youth, especially on youth mental health, but of course, even in other aspects that directly benefit the youth. This is in line with the 2022 World Mental Health Day, which theme is or was make mental health a national priority. On the left is a photo of dance plus therapy participants celebrating the dance during the D+D session. Then on the right is Dora, our country director, making a remark during our IRGPA dissemination workshop. Below is a link to Thrive Gulu Dance Plus Therapy video that changes or is changing lives that we are sharing today. Our last slide here is on the knowledge products. With the input of the young people throughout the engagement process in the implementation research, we were able to put them together and produce brochures. The brochure has some of the statistics that I've been sharing. It has background of the organization, the targets, and some of the quotes that the youths extended. Then the posters, we have 3 posters, one on signs and symptoms of mental illness among youths, then causes of mental illness among youths, self-help tips for improving mental health, which posters you will see them on the walls, both on the left and the right side. You can delve more into the content later. We also have a case study report which brings into life the comparative analysis between the youths in the urban setting versus the youths in the rural setting as far as mental health challenges is concerned. It is from this case study that we learned that actually the youths in the rural setting suffer more in terms of severe, moderate signs and symptoms of mental health challenges as compared to youths in the urban setting. The knowledge products can be accessed in the link below for more information. Otherwise, thank you so much for being a good audience. Amazing, amazing, amazing. So you have seen what dance can do, isn't it? So I know you have questions. Just hold on there. And one thing that they have not talked about, there was an experience of dance, isn't it? So now you want to have an experience of yoga. Are you ready? Are you ready? So you guys, how many times from since morning have you done a full breath? Anyone? Somebody? So I want you to breathe in, and then I will count. Breathe in, hold, then I'll count to 10, okay? Are you ready? Relax. If you're holding anything, just release. Be free, relax. So in, hold, I'll count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Out. Again, in, hold. 1, 2, 3, 4, 5. Out. So now we do it vigorously, like 5 times, okay? Let's go. We can do this, okay? Are you ready? 1, 2, 3, go. 1, 2, 3, 4, 5. Wow, clap for yourself. So, yeah, thank you very much.
Thank you so much, Chelsea Kim. You can take your water right now if you need to, and then get back to our seat. And then, ladies and gentlemen, help us welcome all the way from Kenya. Give it up for Happy Africa. Keep clapping. Keep clapping for them. Keep clapping for them. Keep clapping in seconds. Keep going. Keep going. Keep going. Keep going. Keep going. Keep going. Keep going.
No, keep clapping until it's your time. Keep clapping, keep clapping. Clap. Wow. That is good. So welcome, 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 and welcome.
Good afternoon, everyone. Hello, everyone. I hope you all settled. We will begin our presentation with a short video of our project, just to give you an insight of what the project is all about, and then we'll go on with the presentation. Thank you.
Being a part of something that gives back to the community, being a part of something this big and this important in my community just makes my heart warm.
The Scars to Stars project is a project funded by the state, of which the project's main aim is to seek interventions on how we can promote well-being for FGM activists and survivors.
So in this session, we were helping the girls to realize or to be self-aware of their emotions. Then after that, to reflect on the emotions that they have gone through and then to express. In this way, it gave the girls a lot of power to be in charge of their lives and to be able to say no, and also to be the lead for the other girls so that they can educate the girls and reach out to as many as possible so that they will not undergo what the other girls have gone.
I saw my stepsisters go through the cuts as young as class 4, but married at the same time. I was so privileged to be raised by a God-fearing grandmother since my mother was by then in school. Despite all that, my dad, they were so much rooted in the culture. I went through family situation when I was a very young girl. I wasn't consulted if you want to do it or if you don't want to do it. Though I went through so much mentorships of FGM, like we used I remember we used to come campaign against FGM, but I was so scared to tell my parents I cannot do that because I've seen all my sisters have gone through it, so I knew I'm not special.
Got an invitation to be able to come and reach out to these girls through yoga as an intervention, something that can at least help them achieve a bit of mental health, especially when it comes to this space, because survivors have been through a lot. And one of the things you want survivors to be thinking about is healing. And yoga is one of those go-tos, well-being tools that is available to people so that you're at least to be able to find healing in a way. It's a bit, it's a bit harder than it seems, as I say, but it's one of the tools available to humanity, and it's been gaining a lot of prominence, in the past decade. Just be able to help, the girls, men, everybody really, just be able to find better well-being.
I always say everything is all about the mind and mental health. Yeah, it's important because once a girl is cut, it's enough. Inaleta trauma kwake. And once the girl is not cut and she is in a society and other girls are cut, pia kuna trauma. So it's really important.
The reason for this project is we discovered that through our interventions, and our interventions are mainly focused on the protection aspect. Then the question was, what happens to beneficiaries, the survivors, after the interventions? Are there any facilities for them to seek some sort of psychosocial help or psychosocial therapy? What happens to them? Interventions.
The mind is the driver.
Sorry about that. The technical issues. I think probably at the end of the presentation, we might try to run the video again so that you can see the whole thing. I was supposed actually to do the presentation, but we noticed for purpose of gender balance. So I'll let my executive director take it from here, and then she'll proceed with my colleague afterwards. Thank you.
Good afternoon. You'll pardon my voice, I have flu, but we will all understand each other. My name is Catherine Motian. I work with Affair Africa, where I'm the founder and the executive director. I'm an activist as well. I'm dedicated to ending FGM and child marriage in Kenya, Tony Narrow County. My colleague Isa is a humanist, a youth leader, and an advocate against toxic masculinity. Hasley is our male specialist, working with youth and women empowerment programs. And today with me, I'm sure as we were drinking our tea, We've seen some beautiful portraits with different stories. So today with me, I'm joined with two amazing young women. So other than reading their story, I will have a session where we get to hear their stories now. I'll say like live, like you get to listen to what survivors have gone through and what they're doing in their own spaces. I'll just request Sarafina, Molina to, with the crowd, just so we will get to know them more better and introduce themselves. So Afia Africa started in the year 2007, but fully operationalized in 2009. And why we started Afia Africa as a survivor, I took it upon myself. I come from Narok, where the Maasais are the most dominant community, and we're so deeply rooted in our culture. And for us, when we do FGM, it's transition from childhood to womanhood. Personally, I went through at the age of 12. So I was already a woman, I was ready for marriage and start my own family. But then again, I went back to school. So we came together with 5 other young girls and we decided we will not allow any other girl from our community undergo the cuts, and that is how we started APR. Our aim is to provide a local platform for catalyzing and amplifying social movement to end female genital mutilation, child marriage, and gender-based violence. Our vision is a healthy, empowered girls. Women exercise their fundamental human rights and have the opportunity to realize their full potential. How we work, we advocate for the empowerment, inclusion, and representation of youth girls and women in Narok County. We believe in dignity, caring about feelings, concerns, appreciation for others, openness to other viewpoints, commitment to understanding, and embracing our many individual differences. We support local grassroots organizations to strengthen their social change communications and develop local-owned strategies informed by national priorities to address local context and needs. So Narok County, 75% of girls have already undergone the cuts. So what we are looking into is out of 10 girls, 8 have already undergone the cuts. So globally, we have 200 million women who have already gone through FGM. Kenya alone, 4 million women have already undergone the cuts. And by 2030, we estimate about 2 million girls as well will go through the cuts. Our literacy level in Narok is at 63% illiteracy. So most of partial removal of the female genitalia for no medicinal purpose. So if I can go deeper, maybe just illustrate what I'm talking about. We all understand how the female genitalia looks like. So we have the clitoris, we have the minora, we have the labia minora. So what happened? So when I talk of partially, for the Maasai, they cut the clit. They've gone further, even cutting the entire thing. But with time, things are changing, and shifts are changing, so they are cutting the clitoris alone. For the Somalis, they cut the entire thing. They even go further, suing. They sue the beat, and then they just leave a small hole for men to pass. My story. We have people who are 60 years who cannot even stand and speak what they went through because of the stigma associated to it. What will people think about you? How will they judge you? So we're still living in those trauma, and as you go move further, you get to understand. So we connected on the mental health bit on support, giving us social entails emotional well-being, psychosocial support that indicates how we think, feel, and behave. The pain and psychosocial trauma associated with FGM affect the mental health of the victims of yes. Our learning goals. I'll give Hasni to proceed from that.
Thank you. So I'll take it from here. So the learning goals that we looked into include, of course, there were 2 phases. There are phases that we began with and also as we concluded. So the first goal, we were looking at the emotional well-being package. That's a product that we actually aimed to develop as a result of this intervention. And because we're working with very few numbers, the 16 survivors that were willing to come out and speak, and those survivors are not the ones on the portrait. The portraits are really what we call role models. So we have been to support the young ones who have no voice by just showing their stories and telling them, well, this is what we are doing, despite the experience that we had gone through as in our youth in a rather small, younger ages. So the first learning goal was if the package, in this case, support to establish most operating pathways for re-entry into the society. And then the second one, the support approach, was it adequate in meeting emotional as well as the psychosocial needs to enable us to draw, as African, to draw conclusions on managing survivors. And the other one is a comprehensive feedback mechanism that works between the actors. These are government and the service providers, the CSOs, government NGOs, the survivors, and for example, us at the Africa as an implementing organization. If they could contribute to effective delivery, whatever optimized, and also that the existing structure able to sustain well-being approach for girls and women survivors, then how do we strongly position survivors? And that is in the structure of support at the county level for sustained support and the entry into the society. So because we are working with a very few numbers, 16 does not conclude to us it cannot give us a statistical significance to really conclude generally for the entire population. And that's why this study does not necessarily produce sufficient percentages for you to relate with. But we shall just give you, because if you say 87%, you're just looking at 12 people or 14 people, which does not necessarily represent narrow county. So this is the people who are coming out, who are willing to go through this and then share the experiences. Like the ED has said, it took her time. So other people actually takes them time. So this was an entry level for people to come in so that you can help us design and develop a mechanism that they can relate with. And this is a document, these are stories, these are booklets. So these people are just coming in to help us pilot and also validate the documents that we're doing. So for those researchers and the statisticians, you may not necessarily relate with this as a comprehensive research approach, but we will say that this is because it came in to help us pilot and standardize what we are testing in our case. So we did, of course, a census approach because there were very few, and four actors who are already working in this area supported the same. So mental health, when we did intersectional for the gender, understanding within the context of operation, which is largely secondary data that we have provided either by the CIDP 2013, 2017, the different annual development plans that we had for that phase, equally for the 2017, 2022, and then the KDHS data that we use nationally really provided us this, and of course UNICEF, UNFPA is also providing some significant data for our use. So mental health remains a pertinent issue, largely not addressed in mainstream support system. So in the CADP, in Narok County CADP, actually the indicator they're looking at for the mental health is actually a mental health unit. And of course Nairobi is not different, because Nairobi is actually looking at the percentage of those who are like recorded as outcome patients. In this case, those presenting symptoms and have been treated. So when we look at those, they're actually looking for, there's no management, there's no prevention, there's no efforts towards the same. So they're actually waiting for those who come out and seek treatment, adverse treatment. And those are the gaps that we realize. So a key informant informed that of course they have no sufficient resources in their facilities, especially now these are hospitals. And just for information, like another bank has only six I would say collectively psychiatrists, but there are more clinical psychologists. And so if there are only six and we are working with a population well over a number of, it's really high. So of course I know in Kenya we could only be having one to session for 50,000, like one psychiatrist to 50,000 people. But Narok is even worse. So and in this case, Narok and Northeastern, which is largely affected by FGM, will actually be targeted to bring more psychiatrists and clinical psychologists to support those people who, because there's a lot of PTS like post-trauma stress disorders that arise from the experience, culturally instigated. So what is content technology awareness on seeking mental health? That's across. It's across because even here in this room we may not necessarily know all the science and symptoms of what's specific. I know depression is the common one, there's stress, there's PTSD, but then things like panic popular. They are all mental health issues, but here people may not necessarily pick them as so. And then poor attitudes among survivors. Definitely, our health-seeking behavior is also a key hindrance for people seeking services. And of course, because the society stigmatizes. Okay, the society stigmatizes mental health, so definitely no one wants to come out and say, I'm seeking these services. In the second phase, some approach, but we had 14 survivors, 14 out of that, and not 16 now. Two had, of course, they are youth, so they are diverse. You expect that they will probably get opportunities to violence. So in this phase, 87% of survivors reported to have understanding on how to utilize. So our interventions were largely therapy, as we had seen, largely therapy, yoga, those things that are quite modern, but we are looking at how do we enable that so that these people to actually speak, come out and speak, and also the portraits that you probably interact with later, because those are all models, what they are going through, and this is where they are. So 13% require handholding support, and in this case, I would not want us to report 13% as a general because of the sample size. So we had just to put it here. But there are some people who really need hand-holding support through this phase. And then 97% promised to utilize this package because it was only done at the end of August. We had finished the piloting and validating the entire document that can be relatable and usable within the context. And then all response acknowledge support groups as a viable channel. So our exit strategy was actually a support group. A support group really brings together activists, or rather young activists, those who are not in the limelight, but they want to come out and speak to help change the younger ones. So support groups will be units that we'll talk a little bit about it as I go. So 97% report improving behavior change. So they are willing to actually seek mental health, but they have not reported to us that we actually sought, but they are willing to actually seek those. They are open to whenever they present certain symptoms, because the EWD package actually provides the symptoms of different, either stress, either PTSD, depression, actually provides the symptoms, the causes, and also the management, self-management. Of course, treatment is at one is at one. So 3% is of the alternative group here. We actually have peer-to-peer, so where you want to talk to someone to help you be relieved from whatever you're going through. And there's also the religious or the pastoralism approach that those are still avenues that they actually use. So men remain vulnerable. Of course, men did not feature loudly in this case because this is an experience-specific approach that we are adopting to adapt or rather a document that we wanted them to use for self-management going forward. So, but men are also vulnerable to this. They could be having sisters, cousins, children that have gone through this phase. They also experience this, and we wanted to find best approaches to integrate them in the future endeavors around mental health and administration and service provision. Most girls are cut at ages of 8 and 12. That's predominantly in Nara. Kulibari, of course, with other hotspot areas. Service providers, in particular, those who focus on support, acknowledge inadequacies in mapping, identification, and supporting mental health patients. So, as I said, CIDP only focused on either a unit provision or focused on how many actually coming out as treated for mental health. So definitely we lack mapping. We don't know which actor is doing what, who hosts that kind of platform. And we don't even know how to identify those people because everyone is scared of seeking mental health services in the community. And because we do not sensitize sufficiently, so it means that we lack those people coming out and speaking about MH. And then supporting mental health specialists, we do not have strong case management follow-up. We don't actually do follow-ups. Once you are outside the facility, I mean, we come back when that arises. So health providers are willing to support persons with symptoms of mental health. However, they also acknowledge the limitation in their resources. Once the CIDP misses this, the annual development plan misses the same. So budgeting becomes a very difficult issue. Narrow County has a policy enacted in June 2022. Older regime, now the new regime has come in. We need to go back to a background check to ensure that they actually feel the need for that policy to come in so that they can regularize, do the process of regularizing it so that they can budget for it. So that's why the research can actually take some years. So I agree that those are areas that we need to strengthen. So EWB support groups as exit strategy. So these are solid units that aspires to strengthen women and girls, interactions, experience sharing and learning, equally generating solutions to other social and economic challenges. They also give the groups leaders opportunities to lead fellow members and strengthen their communication and leadership skills, and also equally interpersonal strengths. Sorry. So on this, the project of to empower women to integrate back into the society for stability. By developing solid products and products that are easy to understand, use, and relate, and those products are the stories. There's a story booklet. There's a portraiture that you see there just for modeling, and then there's the EWB package, which is the self-management document that you can access, work with, and reference when and whenever. And then while almost all respondents decide to replace the emotional package, the page notes a strong mechanism to monitor the implications of the materials introduced. So we do not now have resources to enable us walk through the journey of recovery, self-management in this case. And so we cannot really improve based on evidence that because of this and that, we can improve that document. So we are seeking ways to do that. Our standard is strategy enable progressive interaction among survivors and into the future. And they can also be supported by other actors in the same space. Equally, the economic, of course, it's an integrated approach, so the economic needs can also come in to support the support groups once they are registered and acknowledged by the government. So the service providers are few. There are actually few, 6 in Narok, of course, 100 in Kenya. So that means definitely Narok could be equally be blessed. But then there are few based on the context. And the negative attitude from the community is a major issue. So our desire is that the county government can allocate sufficient resources. That means public participation is key to the CIDP to raise this issue so that the ADPs can actually accommodate reasonable budgeting towards the same. Stakeholders in the sector to unify and promote mental health. That's now mapping. Strong mapping can can actually get the roles different actors play towards mental health services. And then individuals to be sensitive to gender towards seeking mental health. So that is a budget issue that comes from the county. If the county takes cognizance, then we are likely to communities can do, because communities are the most stigmatizing unit, including household level. The project can also strengthen further areas of interest by working collaboration with the integrating of mental health through education, activity, and social services. If of course opportunity that the review of the CBC curriculum can take shape and include some components of mental health, then it will be good to also see the integration opportunities that exist. ICT is key because I'll say from 2009 coming this way, most people access technology. Of course, they access technology largely for financial, but also there's opportunities for them to access for knowledge, just knowledge about this mechanism. So to our donor, thank you. And then so we wanted to, of course, include men and expand the age cohorts, which we did periodically with the age cohort. Of course, men was difficult because we had to contextualize this based on the designing, and so it was really experience sharing or rather history. The support group needs to be handheld in this first 3 to 6 months so that they can form structures, leadership structure, so that they can be held accountable, and also they can get a recognition from the social service providers as a registered unit that can seek either formative funds. Those are going forward actions. And then the EWD packages we need to provide context examples to ensure survivors and activists, regardless of the education background, can access and private packages. These are the products, the EWB one. It encompasses mental health issues with their symptoms and how to manage them. So we had covered 60 key issues. We had, of course, excluded some that people do not think they are, but we are aware that they are covered. So this talks about the causes, the symptoms, and the management, self-management in this case. Of course, in advanced level, you may need guidance from the clinician. And then it talks about mental health causes, symptoms, and management, provide list of providers. But this is context specific, so now the document shared upon basis. The booklet, we have a booklet as well. The booklet is really about the stories of the survivors that you will see as a portraiture. So it allows those of those who have gone through the same journey, and they can be accessed as well. Okay, so
That's it. Did I meet your time? Yeah.
Yes.
I feel like a time bully. I am very sorry, teams of presenters. So, as we wind up, last but not least, this, I swear, this is from all the way from drum rolls, all the way from Zambia, ladies and gentlemen, grassroots soccer. Keep clapping, keep clapping, keep clapping, keep clapping. Hey. Oh, they have a soccer.
You ready for some soccer?
Yeah, not really. Okay. Good afternoon, ladies and gentlemen. You all look wonderful. Thank you very much. My full names are Rebecca Banda. I'm the program coordinator under Grassroots Soccer. Yeah, so before we start our presentation, I would ask the audience to stand for us to do a quick energizer because we've been sitting for a long time. Thank you. So the energizer that we are going to do is very simple. So we'll count from 5, 4, 3, 2, 1. Yeah, so I won't use my mic because I have to do that. Thank you. Please. Yeah, so we'll start with the right leg. So when I say 1, 2, 3, 4, you follow the rhythm. So when we start with the demo 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3. 1, 2, 3. 2, 1. Okay? Yeah. So we are good to go? Okay, so let's get ready. So we'll start with the right leg, yeah? 1, 2, 3, go. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. You also say 1, 2, 3. It's like a song. Okay, so let's go. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4. 1, 2, 3, 4. 2, 3. 1, 2, 3. 1, 2, 1, 2. 1, 1. Okay, so thank you very much. Welcome to the last presentation. So I'll run you through a few slides and then later I'll hand it over to my colleague, Carol. Yeah, so it's nice to present last. Huh? Yeah, so Grassroots Soccer is an adolescent health organization that uses the power of soccer to educate, inspire, and mobilize youth at risk in developing countries to overcome their greatest challenges. And the greatest challenges, I think, from the presentations that we've had is the health challenges, and this is a common challenge everywhere. And so by doing that, we make sure that we promote the young people and adolescents in their communities to become agents of change, because we understand that once we involve them, I think the doctor mentioned in the morning that anything to do with youth programming, you have to involve who? Who? Thank you very much. Yeah. So for us as an organization, we had Karen missing my slide, first slide. So for us as an organization, we didn't just plan to do this project, but there was information, evidence information that made Grassroots Soccer Zambia to submit a proposal to Youth Excel. And we would like to thank you so very much for the support, technical support, financial support, USAID, Youth Excel. It's been amazing. So as an organization, what informed us to embark on implementing the Research to Change project under mental health, working with adolescents living with HIV in particular,
we looked at the statistics, and I think this was highlighted in the morning. So young people in Zambia account for 20.8% of a total population of about 13.1 million people. And this is according to the Central Statistics that was done in 2010. So it was estimated that the prevalence of mental health disorders was approximately 20%. That's quite alarming, right? So youth living with HIV showed that the rates were a bit higher because it showed us a ratio of 1 in 4 experiencing depression. So mental health services in Zambia are minimal and completely absent in many communities. So this was the above statistics. These were an urgent need for us to scale the project and implement it with adolescents and young people living with HIV. So just a quick background. We did a formative research. We gathered data from 2 districts in Zambia. One is in the eastern part of Zambia. We call it Chipata district. And then the other one is the main capital city, Lusaka, for those who know Zambia very well. So we collected perspective from different stakeholders to inform us on coming up with a tool that helped us to disseminate information to adolescents and young people on mental health. And this tool, we call it the Mind Skills Magazine, which was designed using the perspective that we collected from the different stakeholders, including young people, so that as we implement, it will still bring in the soccer metaphor, just like you are seeing, we have a ball in front of us. Then again, we also did the stakeholder engagement meetings, where we also got support, additional support from them in order for us to complete the draft form, and we did the pre-testing of the distribution of the magazine to get their views. Then aside from that, we also trained our coaches. By coaches, we mean the peer educators. I think that's the common language that we use. But in our case, we call them caring coaches. So we managed to train 44 young adult mentors that were helping to facilitate and distribute the magazines door to door, and also conducting home visits as one way of engaging the parents to have a buy-in in our activities. Then we also did the research to change activities that were conducted alongside our implementation. So as you can see on the screen, the first part on my left, that's a beautiful picture. That's how our magazine looks like. So it's got pictures, it's got also text, it's got also beautiful topics. One of them is stay in control, and this encourages young people to know how they can stay in control once they have triggers around mental health. Then we also have a poster there that shows the Take 5 technique that will help young people do the breathe in, breathe out, like the way the MC led us. And this helps young people to really reflect and see how best they can work around their mental health. So at this juncture, I'll invite Carol to proceed with the research findings. Asante.
I work for Grassroots Soccer supporting MND activities. So building on to where my colleague left it, in order for us to appreciate and understand insights and learnings from the magazine, we framed 4 research goals. And one of our learning goals was around effectiveness. We wanted to understand how effective is the magazine as a tool for mental health promotion among adolescents, and to what extent does it facilitate dialogue around mental health? Another area of interest was participant relevance. We wanted to understand, do the young people that we are engaging with the magazine content view it as a tool for mental health well-being promotion and peer engagement, around mental health. Our other layer was around stakeholder engagement, taking into account perspectives from the parents, the healthcare providers, and also, to some extent, influential community leaders on their views around the magazine as a tool for mental well-being promotion. Our last learning goal was engagement with the written content. We wanted to understand to what extent are the young people that we are using the magazine able to engage with the written activities in the magazine for us to better understand how we can modify it and also add in additional content. Next slide. So our research was conducted in 2 provinces of Zambia out of the 10 provinces we have. So we had one done in the urban site, which is Lusaka province. The other site was Eastern province, which is a rural site. So we employed mixed methods that allowed us to collect perspectives from parents, guardians, healthcare providers, using focus group discussions, key informant interviews, and also key informant interviews with the youths that are living with HIV. So as projected on our slide, that is our total reach. So just to mention that our research equally took into account perspectives from both males and females as they were appreciating the work that we were doing. Next slide. So to present our findings around effectiveness, our target was to see a 10% improvement in our program. That's our overall target that we put for our pre-post scores at grassroots soccer. So from the interim sample that we had, we see that there was about 13% improvement across the themes of interest. We see that most items had high baselines, 65% statements, and those had also 70% answering correctly at baseline. The reason for that is when we went in before giving in the magazine, we saw that there was some knowledge around mental health, and that was largely attributed to the fact that this is a layered-on project. The magazine was layered on a project that is being funded by Comic Relief called Strong Minds, Strong Bodies. Then, in terms of our pre-post change area, we have these areas of interest. We see under self-efficacy and esteem, 17% improvement when our initial target was 10%. We see attitudes around mental health. We'll go to the knowledge. It's at 13%, appreciation of the content in the magazine. And in terms of knowledge on services, we see an improvement of about 3 times our target, which was 30%. And in terms of willingness to share the magazine among the youths, because they enjoyed the content and they liked it, they were willing to go further on and share the magazine with their peers. And in terms of the attitudes around mental health, we saw a decrease of negative 13%. Largely, this is attributed to the different information that is out there around mental health. Some information is not factual, and to some extent, we also realize that it's the way our pre-post statements were phrased. Next slide. So in terms of participants' relevance, we see that nearly all adolescents viewed the magazine being favorable. They indicated some of the topics they liked, citing topics such as stress, expressing emotions, build your team, and alcohol abuse. We'll just read out the feedback from a female adolescent in Lusaka who said balance and stress were told about some of the helpful ways of handling stress. I wrote down things I like singing, reading, doing exercises, and taking deep breaths. When I was stressed out with academic work, I used them and they worked, resulting in me studying more. Again, moving on to our other side, which is rural, that's Eastern Province, we see that there is this quote which is to support the finding around the common negative feedback that came from adolescents as well was around difficulties in the English content of the magazine. And one of the adolescents told us, the first challenge is that for adolescents in my village, they don't understand English. They should translate in Nyanja. For instance, questions can be both in Nyanja and English. Next slide. So among stakeholders who are the parents, the guardians, and also the health service providers, we see that they positively viewed the magazine, but in many cases reported that they were not familiar enough with the content to give specific feedback. This again will speak from our distribution approach, because our distribution approach for engagement with the magazine was directly to the home, focusing on this young person, away from the health facility. The health facility were only engaged in the stakeholder meetings to give their perspective and views on the magazine. So we see that another feedback that came in from the parent around the magazine was also citing the lack of English literacy and busy schedules as one of the reasons why they couldn't fully engage with the magazine, and it was very difficult to get their perspective. In Eastern Province, again, one of our rural sites, one parent indicated, it's hard for me because I can't manage to read. There is a neighbor who can read English, but they are usually busy. So due to the distribution of the magazine directly to adolescents, most health workers and caregivers didn't have an opportunity to engage with the content or look at it, but they were familiar based on the stakeholder engagement meeting where they gave their input in the content development. Next slide. So among adolescents that engage with the written content, if we go through our magazine, we'll see that there are some spaces where we're asking these young people to write some of these things. So for those that went on to engage with the written content, we see that there were differences in terms of understanding and engagement in terms of the magazine, but generally we saw some positive feedback. But again, when we try to look at variations across the rural site and the urban site, we see that those in the urban sites, which is Lusaka, demonstrated a better understanding than those in the rural sites. Again, it goes back to the English content, the literacy levels, and the like. So not all participants, again, engaged with the written activities in the magazine, citing busy schedules such as schoolwork, chores, and also other community activities like being peer mentors. And again, we have good feedback from the young people. They went on to tell us that we should improve the magazine content in the next phase because they wanted to see the magazine in the local language. And they wanted us to add more spaces for them to write. They went on to say, can you please clarify some instructions that are not clear and add more jokes and puzzles that should be improved on. Next slide. So this is just to appreciate the written content of the magazine. Those are some of the adolescents that engaged with the magazine and what they wrote. We see that there's one adolescent who went on to type on an extra paper because the spaces were not enough. So our key takeaways. What are we learning from this project? What are we learning with support from USID, Youth Excel, and IREX, and the 4 partners that we were engaged with? We have learned that the magazine is effective, acceptable, and relevant to participants based on their ability to demonstrate that they are willing to share. We see about 17% say they are willing to share the magazine. Again, the magazine appears to be a supplementary tool, that is an enduring supplementary resource that is repulsing mental health content. Young people recommend that the magazine be translated in the local languages, add more space for us to increase our reach, even those youths that are unable to read or write in English, but if we take it down to the local language, we'll be able to expand our reach and leave no one behind. In terms of health workers and caregivers, they alluded to the fact that we don't need to work outside their framework. We equally need to engage them more with the magazine distribution and try to take it at facility level. Positive effects of the magazine were noted or guardians of the youth that were living with HIV. And in addition to that, parents were comfortable sharing their feedback around the lack of English literacy and busy schedules are some of the hindrances why they didn't really engage with the magazine. Again, we have learned that our research tools to some extent had some negatively worded pre-post statements that might give an explanation for the negative 3% we saw around attitudes of mental health beyond other activities or other factors outside our control. Next slide. So given these key learnings, what are we? Okay, so in terms of result adaptations, these are the listed adaptations, and some of them are ongoing and others have been actually taken into effect. So one of the key adaptations we did was to engage parents or guardians with the magazine by taking into account their convenient times. We reverted to distributing over the weekends when the parents are home. Another approach we took was to provide group-based delivery. Away from distributing at household level to this one individual, we went on to distribute at group level so that we can facilitate discussions. For those young people that had challenges with the content, they could easily get clarity from their peers. Another adaptation that we are considering is extending the magazine to youths outside those living with HIV. We have seen again there's that willingness to share the magazine among young people. And that also drives the point home that even the young people themselves, they do realize that mental health is an issue and they are willing to pass on the information to the next young person. Again, extend the magazine to health workers and review the magazine to take into account literacy by also using simple terminologies. Next slide. So conclusions to the government and partners, our recommendation is we should scale up the implementation of community-based youth mental health interventions. To donors, we need to invest more in mental health interventions. We are very excited to learn that in Kenya, the government has attached importance to mental health based on what was shared with us in the morning, but additional investment is needed. Civil society organizations that are working with young people and those that are working with other key priority populations, we should extend mental health interventions to other young people outside those living with HIV, because mental health cuts across. We have seen our statistics from the background has shown that 1 in every 4 person has mental health. I don't know on our table who is that 1 person. Okay, so all implementing organizations should also take into account the local context. When we are designing interventions for mental health, let us not ignore the local context. If it's in Nairobi country, yes, if the language there is Swahili, please let's not take a product full in English. If the language is that local language like Nyanja, let's take into account the local context so that we can expand our reach and ensure everyone is included. So building on this research work, we have produced a video that can be accessed from our website, Grassroots Soccer Zambia, and also on our Facebook pages. Thank you so much. The timekeeper is a very strict lady.
Thank you. You can take your turn. Thank you so much, everyone. Thank you, MCQ. So right now, we'd like to get to almost the favorite part of the day.
Sure.
I know someone was looking forward to that part. She's looking at the side, but cool. We are going to take a lunch break. It's now 1:42. At the door, Shiba and Edmond have meal cards.
Yeah.
So kindly pass by and pick one and head straight.
Michelle, just a minute. We'll have Sylvia talking about what will happen after you have had lunch.
Okay, okay. So before you leave, kindly ensure you pick a meal card. Sylvia is going to give us way forward. Can we meet back in here at 2:45 p.m.?
2:30.
Okay, that's a stretch, but let's try and get back here at 2:30. You can take your desserts if it's allowed inside here. Okay? Thank you, Sylvia.
So give it up for Sylvia.
I won't stand in the way between you and lunch, so this will be very brief, but I really want to appreciate all our partners. Can we give them another round of applause? Okay. Implementing that I need to be aware of so that I can make relevant adaptations. So it kind of starts to form it starts forming the thinking behind the actual like implementation research or research change work that is done. So that's why you see like even you had Rock of Hope talking about the fact that they realize there's also inequalities within the LGBTI community. So those are those kind of insights that the IRGPA can give you. And so this is accessible to on our page. So if you go to the irx.org, then /youth excel, you'll be able to learn more about that. So something else I wanted to talk about is I hope as the different participants have been, sharing their presentations, I'm sure you've seen like similarities, right? Similarities in terms of things, things that are successes and challenges. So I think we are in this room, we're all in agreement that youth mental health is an urgent issue to address. And I think we've also seen some, fair share of successes. And I think youth responsive methods of tackling mental health issues has seemed to be successful. We've also seen the benefits of using peer-led approaches. So I think for all the organizations, they've been working with peers, peer-led or youth-led approaches or youth with lived experience. So I think that's something else you can pick as has been successful. And again, there are also similar things you're learning. I think right off the bat, some of the things we've seen that are common across the different continent or different countries rather, things around the high link between poverty or lack of economic opportunities and mental health. So I've seen that come up and I hope you also were able to pick that up. We've also seen the limited inclusion of males in mental health interventions, despite the fact that statistics show that, for example, here in Kenya, those who die by suicide are more, males are more than women, and I think that's true for a number of contexts. So with that back, what we want to do when we come back from lunch is to arrange ourselves or to move according to our interests. So we'll be having each of the organizations representing one group. So again, we're going to be having 4 thematic areas around youth living with HIV, around LGBTIQ communities of youth, around youth in conflict areas or post-conflict areas, and the last group we'll be talking about is, of course, the FGM youth. And so what we want to do, we've not given you an opportunity to ask questions, but it's been, we have a lot to cover today, so bear with us. However, when you come back from lunch, you will come into the group that you're interested in learning more about or that's most relevant to the work that you're doing. In that session, you'll be able to get more information, more than the quick slides, which are very strict. MC was keeping time. So you'll be able to get more information. You'll also be able to share if you have any experiences that are similar or different to what has been shared. And then what we want is to also spend some time to think about how can I take what I have learned and how does that affect me. So for example, some of these learnings can be shared across different, it doesn't have to be, for example, you only use a magazine when you're talking about youth living with HIV. Perhaps you're just talking about, youth who are recovering from, drug use, for instance. So is that something that you can use? Is a magazine-based approach something that can help? We've had like sharing of stories, storytelling or talk therapy. Is that something that you can use with the youth that you work with? So you want to take some time to think about, based on, what we are learning, querying more about it, validating, trying to find out what's similar and different. We also want to take some time to think about and to actually put into action plans, a small action plan. What are some of the things that we can take away from this summit that we've had today that you can, very easily, maybe in the long term and in the short term, be able to adapt into our approaches. So that's going to be the main work that we're going to do in the afternoon. So yes, please go have your lunch, but we still want you back. So don't say like, okay, it's a wrap now. There's still a lot that we have for you after this. So thank you very much and enjoy your lunch.
So the lunch starts from now to 2:30. I know you haven't started, but you start from now to that. So enjoy. Jake.
Yeah, it's okay, yeah. So what would be interesting you? Ah. Yeah, that's yeah. And then you have a sign, you have to sign. Anyone can, I haven't looked at the It's really important. No, I want to come back, but I know how to do it. I just don't want to be. Okay, great. Let's
That's part of what my own.
Yeah, so
So I presume that there is no interruption. We have one group. We have another group here, another group at the back, so there is some distance. So the second one, we will push this table to join this table here. Group 2, then group 3 here.
and then group 4. Okay, so minimal disturbance.
Yeah. Tables combined.
And they're already kind of seated. Like we're gonna need like group of hope. We're gonna
If that is there just because they have all stuff
Yeah,
there.
there's stuff there.
Yeah. The one thing, like, you know how it cost us, it was about $6.
Yes, yes.
About $23.
Yeah, then call it $23.
Well,
No, so far so good.
Yeah, no, I mean nothing.
That's fine. Not better in terms of time, but really, I think we're fine. Because for me, we start exactly at 2:30, then do good session, 4, then wrap up. By 4:30, we should be done. Yes, yeah. I think 1.5 hours should be enough for them to finish. Peter.
Yeah, I think they're bringing it now. So.
So watakuja wataleta kitu yao baadaye. So that's good. At least mtafika in good time. Hiyo ingine ingefika very late. Sawa, tutaongea tu baadaye wakifika. Yes,
Okay, yeah, that's good. Oh, let me read this first. What I give you. JK. I'm remembering what happened in Millsview. So what do we do? Okay. Yeah.
Tulipokuwa tukicheza twisti, sikujua
Project is discovered that through our intervention, mainly what are these stories I've been taking in my head? Why have I been giving them so much attention and energy? So the idea is now to bring them into the space, them calm down, focusing on their breath in and out, then find just ready and cheat. The Scars to Stars project is aimed at promoting well-being.
watoto wana njaa, sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Kwa usema fungeni milango, anakuja. Bwana nipe pesa, watoto wana njaa, sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Sema fungeni milango, anakuja. Watu wote wa Kibera wamuona kila siku, kuingia nyumba zote za pale kanisa. Tafadhali Bwana rudi, watoto wana njaa, sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Kwa usema fungeni milango, anakuja. Watu wote wa Mombasa wamuona kila siku, kuingia nyumba zote za pale kanisa. Tafadhali bwana rudi, watoto wananja, sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Kwa usama fungeni milango, anakuja Wadawida Wadawida daruo muamwasina esirade mwana edeviranya inyo chamuzi
Wadavida daruo muamwasina esirade ko mwana edeviranya inyo chamuzini. Babo Juang tuende.
Mamo Juang siendi.
Babo Juang tunaenda.
Mamo Juang, nimesema siendi. Nyinyi wanawake mnakashechi, mkishajazwa akili kwenye chama, waja hapa kuniambia eti tuende kliniki, eti niandamane na wewe nikapimwe damu. Hapana, wewe nenda ukapimwe.
Msikie, waogopa nini? Kama unajua umekuwa mwaminifu, mbona tusiende pamoja?
Mimi na mwanamke tuende kliniki, sahau.
Siku za densi. Happy Babo Juang tumekawia. Samba Mapangla is in town. Si tukavunje mifupa. Najua bado meno iko. What has changed? I ask, what has changed? It is item as couple. We take this bold step and now our status.
Women are so weak. Why do you have to rely on men? Do you want to use me as a shock absorber? Do you want my shoulders to lean on? Surely, Mamo Juang, it is simple. You have the interest. That is good. Take the test, know your status, and take the results like a man. Ama umekuwa na mpigo wa kando.
Msikia anavyoongea. Ni wewe wantia wasiwasi. Umenipeleka densi mara ngapi? Na umelala nje mara ngapi? You only take me to your staff parties just to save your face. Na zile zingine, nashuku sana una mpango wa kando. The other day, you had lipstick on your shirt. Nilivokuuliza, hatio, kalamu ya secretary ilianguka. Atio, nilipojaribu kuiokota. Ati, spare me that crap. Uongo mtupu, hata shetani anajua. It's total lie.
Enough. Kwa hivyo uniamini, nina mpango wa kando, si ndio? Ushawahi muona? What's her name?
Jerry.
And her hip size? Mama Ojwang, usinifundishe uongo. Take the test na matokeo yako itaonyesha mwenendo wako.
Exactly. Hold it there, just there. Even you take the test na matokeo yako itaonyesha tabia yako. Stop being rigid. Stop being overprotective. You know yourself. If you have been faithful to me or not. Kwenda VCT ni rahisi kama wimbo. Tunatoka, tunaenda, tunapimwa, tunajua kama tuko nayo ama hatuna. You see, let's take the test and know our status. Come on, Babo Juang. Twende.
I can see I married a genius. Sometimes I tend to think it's Peter that made me marry you.
Wacha mtani wewe.
To all Babo Juangs and Mamo Juangs, it is clear. Statistics are out. Most of the new infections
within marriages.
It is high time we reverse the trend, cleanse our union. As couples, let us take the bold step, know our status. Hali yetu tukijua, tutajua ni ipi tutaichukua, kuishi maisha ya kishua. Let us go for VCT and know our status. Wewe, wachana na mpango wa kando, uepuke ukimwi. Thank you.
A better round of applause, please. Kim, where's your microphone? I want to tell you something.
Here it is.
You know, deep down, I want to be a Mama Ojwang.
Yeah, you can try that. Can we do a skit here with you?
No, let's try that next time.
Don't shy away.
Did you enjoy lunch? Welcome back. If we had any of the members who did not officially leave, who is not here, and you have their numbers, kindly prompt them to tell them we are getting started. Kim, lead us to the next session. I am
Show. The next show.
No. Not sure.
So even before we move, those are young people who uses their talents to create awareness on various issues. They are called wasani sana. So in case you have an opportunity for them to create awareness on different issues, kindly reach, I don't know where Vincent is out. Vincent is out. So you can always contact them and they'll give you that opportunity to create awareness. We call it edutainment, where you use entertainment and kindly give him the mic. This guy has a lot of energy. Yeah?
It is edutainment where you use entertainment as a tool to educate. That is
Wow.
edutainment.
Where were you? Clap for him. So right about now, allow me to call this big guy here. This guy is a mentor. He has mentored me through emceeing. And sir, I am very humbled that I'm here with you. And you're humbling and letting me MC. And you're still around. That is mentorship, isn't it? Clap for him again. Thank you very much.
All right. Thank you very much, David and Michelle, for a job well done. Let's give them another round of applause. Yeah, I told David when I saw that he's one of the confirmed participants, I cannot MC when he's there. I have to see how my mentees are doing. Sindio? All right, so welcome back for the afternoon session. I'll keep this very short. I want us to go to the breakout rooms, and the breakout rooms are not outside. They're just within this room. All right? So as the presentations went on, we asked you to identify with which presentations you can relate to more in terms of the work that you do, or you have more interest to go and to interact more with them, to ask more questions. You realized that as they were presenting, we only gave them 30 minutes, but now we'll have about 1 hour, 15 minutes for you to interact with them. They'll tell you more about their projects, things that they didn't say in their presentation. If you have any questions, use your time to interact with them. And apart from that, then you get to know then what's the way forward from here. Are there things that you want to take beyond this meeting? Are there partnerships you want to create? Yet I know some of our grantees are not in Kenya yet, but who knows? You can create partnerships, out of these conversations. And before I forget to say, my name is James Karongo. I work for IREX as a regional program officer supporting our partners in the Africa region. So we have this side of the room. So you guys can combine the two tables. So in this corner, we'll have grassroots soccer. So that's where grassroots soccer will be. And they have the guide for the facilitation, and they'll be supported by Frank, my colleague, who will help us to take notes for that group. So at the front here, again, we'll combine these two tables. Here we'll have the team from Uganda, Thrive Gulu. So if you have any interest around dance and therapy to understand more how that dance helped reduce the different mental health issues that were identified. So please feel free to join the dance and therapy team here at the front. And that team will be supported by, again, my colleague Chris, will help us to take notes for that group. Then we have the team from Eswatini, Rock of Hope. They'll be at the back there. They'll again combine those two tables. So if you have an interest to learn more about the LGBTIQ work that they were doing, the life skills, the entrepreneurship classes, the counseling things that they were doing back in Eswatini, then that's where the Rock of Hope team will be. So if you have interest to learn more about the FGM survivors, the storytelling, the scars to Stars project, this is where the Africa team will be. They'll combine those two tables. So that's where the Africa team will be. So one final time, in this corner, we'll have grassroots soccer. At the front here, we'll have Thrive Gulu. On that corner, we'll have Rock of Hope. And here, we'll have Africa. So, as I said, it's 3 on the dot. We'll finish the breakout rooms at 4:15. We come back, wrap up. So by around 4:30, we are wrapping up, having tea as we go home. Sindio? Awesome. So thank you very much for listening. So let's move to our groups, to your group of interest. Just carry all your valuables with you, because we need that seat where you are seated for the team that will be coming to do the breakout room there. So anybody interested with grassroots soccer's work, this corner, dance and therapy, we are coming to the front here. Dance and therapy, the counseling work, entrepreneurship by Rock of Hope and the LGBTIQ community at the back there. And then the work around FGM and the activists and the survivors will be just behind here by Afia Africa. So guys, let's move to those sessions. Yes. All right, and we'd also like to recognize the presence of the CEO of the Anti-FGM board. We'll give her a chance later to say hi to us, and we thank you very much for making time to be with us here today. So people, let's move. Feel free to combine the tables. Tumewapea ruhusa. Feel free to combine the tables. Just feel free. Sorry. Just feel free to combine those tables as I've advised. If you need more tables and seats, just pick around the class and let's get the groups going. And for Afia Africa, Edmond will help us to take notes for that group. Edmond from Youth Alive. Thank you. So for GRS, Frank, I can see Frank there, I can see Chris here, Rock of Hope, Diego, thank you, and Edmond. So we are set to go. So we'll stop at around 4:15.
Through providing
if you need help to identify where you want
which will be the end result of the entire
you can
project,
just talk to me,
which can also be replicated by the people that the participants will have trained, and these are the activists and survivors from youth-led organizations, and they will have to replicate what we told them to go to their respective wards and area of operation to do the same to other survivors to ensure that this whole aspect of well-being is replicated in all the wards in our county.
So if you have that interest, please be here. I can see the Rock of Hope team and the people who are interested at the back there. So we are set. And the Afia Africa team. Awesome.
Being a part of something that gives back to the community, being a part of something this big and this important in my community just makes my heart warm.
The Scars to Stars project is a project funded by USAID, of which the project's main aim is to seek interventions on how we can promote well-being for FGM activists and survivors.
So in this session, we were helping the girls to realize or to be self-aware of their emotions. Then after that, to reflect on the emotions that they have gone through, and then to express. And this way, it gave the girls a lot of power to be in charge of their lives and to be able to say no, and also to be like the lead for the other girls so that they can educate the girls and reach out to as many as possible so that they will not undergo what the other girls have gone.
I saw my stepsisters go through the cuts. His youngest, class 4, got married at the same time. I was so privileged to be raised by a God-fearing grandmother since my mother was by then in school. Despite all that, my dad, they were so much rooted in their culture. I went through female genital mutilation when I was a very young girl. I wasn't consulted if you want to do it or you don't want to do it. Though I went through so much mentorships of FGM, like we used I remember World Vision used to come campaign against FGM, but I was so scared to tell my parents I cannot do that because I've seen all my sisters have gone through it, so I knew I'm not special.
Got an invitation to be able to come and reach out to these girls through yoga as an intervention, something that can at least help them achieve a bit of mental health, especially when it comes to this space, because survivors have been through a lot. And one of the things you want survivors to be thinking about is healing. And yoga is one of those go-tos, well-being tools that is available to people so that you're able at least to be able to find healing in a way. It's a bit, it's a bit harder than it seems, or as I say it, but it's one of the tools available to humanity, and it's been gaining a lot of prominence, in the past decade. Just be able to help, the girls, men, everybody really, to just be able to find a better well-being.
I always say everything is all about the mind and mental health. Yeah, it's important because once a girl is cut, it's in a letter trauma kwake, and once the girl is not cut and she is in a society and other girls are cut, pia kuna trauma, so it's really important.
The reason for this project is we discovered that through our interventions, and our interventions are mainly focused on the protection aspect, but then the question was, what happens to our beneficiaries, the survivors, after the interventions? Are there any facilities for them to seek some sort of psychosocial help or psychosocial therapy? What happens to them after these interventions?
The mind is the driver, the body. And if the mind is not okay, then the body is not okay.
What are these stories I've been creating in my head? Why have I been giving them so much attention and energy? So the idea is now to bring them into a yoga space, help them calm down, just focusing on their breath in and out, and then they're able to find that bit of serenity and peace.
The Scars to Stars project is aimed at promoting well-being through psychosocial support, through providing a package, which will be the end result of the entire project, which can also be replicated by the people that, the participants would have trained, and these are the activists and survivors from youth-led organization, and they will have to replicate what we taught them to go to their respective wards and area of operation to do the same to other survivors, to ensure that this whole aspect
going to guide them through the journey of the 12 weeks. It also gives them the benefits of the dance. So during this safety and stabilization, they're also taken through some of the skills that can help them when they are going through difficult moments, among which is the deep breathing exercise, whereby they are taught to take a deep breath to calm them in a difficult situation. They are also supported to come up with their power statements that
The
give them
Scars to Start
comfort and
project is
confidence
a project
to
funded by
take on their
USAID,
difficult moments.
of which the project's main aim
There are
is
some of
to
the skills
seek
like
interventions
encouraging
on how we can
self-talks
promote
that they
well-being
are also
for
equipped with,
FGM
so that
activists.
For the cross-border women traders in Amanga, Busia, and Kwale. And lastly, we are members of the East African Community Gender Departments, where we further the discussion on Kenya-based gender issues to the EAC level.
Thank you.
Cross-border women traders. Women traders, yes, at the borders. So at the cross-border women traders, we build their capacity on labor laws, but also empower them with financial literacy, as well as engage the counties at the borders, Kajiado and Busia, in coming up with childcare facilities that women can leave behind their children as they cross over to go and trade. So we are kind of protecting the children not to be exposed to GBV cases at the borders.
Thank you. Any other that I've left out? Have a minute?
Yeah, my name is Felix Milama. Yeah, I work with UNFPA. I'm not in Kenya. I work in UNFPA Somalia. And I think many of you know what UNFPA does. We have 4 areas that we focus on. We have the area of sexual and reproductive health, which works to ensure that no man should die giving up. So we end all the preventable process of pregnancy. Of course, we work with the millennium at the the second area of focus is gender-based violence.
Yeah.
Gender-based violence is our second area of focus. And this is we work to ensure that a woman is protected in all ways, to ensure that they live a fulfilling life. And then within the gender-based violence, we have also the issue of FGM, which is the core subject that we're discussing about, to make sure that all the harmful practices are ended, and also preventing early pregnancies and protecting our young girls. And the third area is dealing with the youth. I know the youth in most countries, like Kenya, which is my country, they form a substantial proportion of the population. We are a youthful country, so we believe in protecting the youth to ensure that they fulfill potential. And then lastly, work in the area of data production, which is supporting major surveys and censuses.
Thank you so much. So he was talking about UNFPA, but he's based in Somalia, like UNFPA Somalia, not Kenya.
Yes, because we had
within our courses whereby they learned how to start just a basic business. So they were able, I think they were, how many who started their businesses?
Yeah, 5. One transgender participant started a whole transgender CBO for themselves. They started mobilizing people that they know. And then the second transgender person is now doing a baking sort of business, trying to cater to needs of other CPOs with breakfast meetings and such like that. So we are offering the space where they can grow themselves. And then other people applied, they came to us, we helped them with the CV, with the design of everything, printing out the letters, and they did report that they successfully got the jobs with an client. So yeah, but I think now we can leave you guys to ask questions. Something with me too.
Allow me to go first. They call me Mohina. I support projects for Badly Africa is of the most women's rights organization. I currently piloting a mental health project. It's 6 months. We are 3 months into implementation. In the project, our direct participants are young women between the ages of 18 to 68. Oh, young adults. We have participants between the ages of 18 to 68. And also we've introduced the social spectrum into the implementation. We are big in Sochi. So we have partners that is working with that is Uskimia, who are largely funding the interventions for the Sochi spectrum. So 3 months into implementation, now allow me to just give background of the work that we use. So we have 22 trained mentors that are directly with project, and then we've assigned those mentors with mentees, and so they're the ones who act as a direct contact as peer counselors to the mentees. Sitting in the conversations because it's community based largely. So we have the interventions at the community level. Sitting in the discussions, I think two things always stands out when people are talking. That is lack of finances, and sadly, men. So we are largely working with women, so men will always come up with the conversation. And right now, since it's a pilot and we have room to scale it up, we are thinking that we were just sitting reflecting that how can we be able to incorporate. I really love the idea of incorporating the economic aspect into the project. I think that is something from out of that is something a learning that I've gotten. Because it would really solve a lot of challenges. Because if 80% of the participants keep mentioning it's lack of finances and then how are we going to moving forward incorporate men in the discussions. We don't work with men, but then how then can we be able to incorporate them into the discussions? Because if there are root causes of many of these problems, then we know them, right? So I think that is one of the greatest learnings of water from projects that you have. And 3 months into implementations at the community level, that we are getting a lot of pushback when it comes to religious leaders. It's a community activities, it's community-based activities. That means we largely have to work with community leaders. We have buy-ins from that is the chiefs and things like that. But when it comes to Mama Kanisa, with women of yes. Women girls. I would say women girls, right? When it comes to women yeah. So women please go with Mama Kanisa. when we're working with these women who are very integral in the project activity.
Along the way as we enroll new groups, they can yes, it's my brother. Then we work with the
Okay. In the end of the motion,
Any similarity?
By doing this, I think can release a burden, anxiety, emotion, depression, slowly by slowly. This is the highest time we are coming out and telling the story. And I think in few months or in a few years, I think there will be some
The name of the organization is what?
women rights.
Thank you. So in our findings, we also closely align that there are significant gaps because resourcing is a large issue, but we know resourcing is based on evidence. Because we lack that evidence from the county, they cannot commit. Even the person developing the CIDP, the consultants that are tasked to develop a CIDP cannot relate to what is the context like. So they really largely rely on secondary data. And equally the secondary data, like we do not have the EHS 2021 yet. And so we are hoping that, of course, if it comes, it will significantly make a change the current situation. But now the 2014, the 21% that we use at a national level, when you try to contextualize it and say 17% in narrow, people do not closely relate to what you mean. It looks like it looks negative. That why are you pointing stuff the worst performer in terms of FGM? And why are you pointing Garissa to be 92%? Why do you look like? But then the national level is actually 21%. And because the people do not, the county specific teams do not necessarily relate to the data, and they do not have resources and mechanisms to actually collect, map, identify, resolve, case manage, even follow up. They hardly own up. So when you come in with the proposals that because your area is largely affected with this, and they don't relate to that largely impact that their people are feeling, then they actually do not take action. They feel that you are outside, you are marginalizing them based on data that they don't resonate with it. After all, they know the Kenya KDHS also will have significant gaps in terms of how they collect the data. So they also bring out the assumptions that there's already a marginalized perspective towards our communities. So that's how we end up having CIDB's significant gaps, how to handle the relationship, the marriage between FGM and mental health. And because they do not capture that, when you see the indicators of the CIDPs that we have, they are very weak. There are people are just thinking if we have an extra unit, I think that is a way to end to address mental health. Or if we have an extra GBP center, that's a way to cap the FGM. But they don't talk about. So when you look at it, people are looking at the treatment, but there's a lot of before treatment. There's management, there's prevention. There's a lot of things that comes before then. So our course was actually to identify which tool can self-manage. can help you self-manage your own costs, because mental health is very broad. And while we focused on stress, post PTSD, while we focused on depression, because depression is the most worldwide use. There are things that are very easy, like phobia, like panic, that are actually left out, and everyone, someone could actually. That's why we are affected by that. All of us, in one way or another, are affected. The degree is different, but that's how it's actually the truth. And then if you try to ask someone, why don't you seek services? And you actually know that you are either stressed, the stressing level could be actually be higher, and it could be focused. Maybe it's a trauma cause, or any other. Not only just a gem in this course, but even those people in accidents, and those people don't seek mental health support, and they don't seek it because there's a definition. It's already stigmatized by the society. It's once means a gem, because the gem is perceived as right in certain communities. And so an accident will actually be understandable that you went through this, so someone will actually support you on a basis that, on a humanly basis. But when you come in with a cultural practice that you define in your own cause as harmful, yet their resonation is that this is right. I mean, this is the way it's done. And they actually give you that, we have 1, 2, 3 people who have gone through it and they are still successful. We still have children. Still, so those are the biases that you face. You actually face that on the ground. And in that case, it becomes very difficult for you to immediately see changes within the community. Even if you buy in a political goodwill is also riding on the goodwill of that community. So for them to fight back on that community on a basis that we introduce law for forest enforcement, or the arrests and prosecution and every other thing, they will also know that their contract is either 5 years or 10 years, and so they will also feel the threat is actually real. So those are the issues that you try to say, how do we address them. So that's why partnership is key, and it's good to understand who is playing what role, what point, so that I know some of you are even higher national policy level advocacy, others are actually grassroots advocacy, and all of them play a significant role. Partnership is where we need to strengthen. While we do not have strong, we have actually have strong donors. Of course, strong donors are using this localization aspect. So as much as the strong donors are at the top, targeting organizations that in Kenya, for example, and maybe the Kenyan organizations are granting the actual grassroots actors, then we still miss a link in how best can we coordinate, because the top level, they will support us financially and to an extent technical, but the technical part is actually to ensure compliance reporting. But then how do we then come on the ground and see how can this thing be really addressed? If you say dialogues, if you say social change communication, if you introduce behavior change approaches, how are they working? That data is missing. It's actually no evidence that approach A, B, C is sure way of exiting this practice. We say that they use alternate ARPs. So their ARPs, they have dedicated elders to come and bless the kind of blessing. But you see, the blessing could also be camera based. So if you try to go beyond what that blessing is back to the community, you realize that the gaps actually still, they could actually be widening. It's the same way when you have elders in church who are actually leading on key areas, and they whenever they speak in church, they are listened to. But when you go to the community, also they speak well for FGM, and once they speak, then nothing else works for your resources. So those are the challenges that we face, and we wonder how best can we eradicate this. Yeah. So if you know, of course, if you know, and you contribute significantly to the reduction of prevalence in whatever area, small or big, how best did you do it, and how did you monitor to really see that this is a significant change and contributing, and can you attribute it to your interventions?
Again, so what things as unclear, what can we take on as a next action in terms of research around mental health and needs? Yes. So for me, what I the element was let me say this. Say, I could say men, millions of them, supposed to be
For that submission, yes. What I picked from the presentation, actually what for me remains clear was involving particular ability the different platforms. For instance, for soccer, we have a productive soccer. Nobody has talked about it. For magazines, we don't have any magazines in grade. So I thought that we cannot be able, especially there, we cannot be able to access that. Even on the dance platforms, what dances can we have to also work physically able? And just trying to involve this because we have so many youth who them have acquired stability, and I think after acquiring a disability, they start being very functional like right now, and then you acquire stability. Other then you get into depression, you get some mental illness. And this is an outflow that we need to factor in as we are considering this report.
One selection we have talked about the person being with something, but you're not talking about the community they go back to. We're not talking about the parents, we're not talking about the people that might be, yes, I have gone to this soccer game, I'm coming back home, or situation changing. So the environment around the person benefiting from all this observation, something that you know.
Yes, there was a hand.
Yeah. What was that idea? How they feel the intergenerational thing. And what I was thinking about in a way that why did you come up with intergenerational dialogue? Parents and guys and the children able to come together, able to share. That is one thing. Then another one in terms of self-care. And this basically was going, I think, Africa. Because I had something about it in terms of the survivors who are going. What are some of them? Yes, they tell their story. What are some of the self-care approaches they are using? Because they're telling us, like, there are some who are they are fearing to open up. And maybe they can be able to give some of the platform the survivors use something self-care through that approach and then reach out to more. So that is these two. Yeah.
Personally, what I picked is the issue of language barriers, whereby English was not really the thing. It's not as maybe you have the magazine. There are people who not need the information, whereas they need it. Maybe you need rather than just now wanting, I don't know, but I just feel like rather than just doing using the law for why don't you like make it possible for people to learn English? So you can't add that one.
I think to me, I would really be interested to know from both four presentations, they shared so many things about data. And I would really maybe like to know or to suggest, because data is one of the very, very important and key things when we're dealing with the issue of community work. So what kind of a platform, or is there any, maybe in future, can there be any other technology platform that can be used so that we can be able to capture the data? Because for me, I feel like we missed a lot of where did we get this data from? Because we could have maybe we sampled 100 people and they did it online, or we sampled 20 people and they met. So we could maybe really want to know more.
Thank you.
I think once right now, mental health has a lot of persons who are coming to mental health. They are not specialists in mental health. They are not psychologists. They are not psychiatrists. So I'd want to see a more engagement of non-specialized persons in mental health. I think if you ask us around here, you'll hear very different professions. But we did one reason or another, contributing towards the theory of change in mental health. So the use of non-specialized persons, community health volunteers, in these in the implementation aspects of it, I think will go a long way, because even training these standards of mental health is even difficult, and they can never be sufficient, even in our own country. So if we adopt that aspect of engaging more of non-specialized persons in mental health, whether they are advocates in mental health, whether they are economists in mental health, whether they are sports people in mental health, I think that will have a long lasting impact.
We have submissions. From you, Thank you so much. So, any other submission?
Sorry, building on what you're saying, you all presented about the adaptations or adoptions you're making to your approaches, your organization system and strategy based on the data. But this is just from a snapshot in time. So youth excel funding is over. What are you planning to do consistently and regularly to collect these data from a larger group of different time snapshots, to continuously inform what that you're doing? So to do something like this with a community that you're supporting. I don't know if the youth that you're working with had a chance to sit and interact with the data, validate it, tell you if there are gaps, accuracy in what you're reporting, such things. So how are you going to do this sustainably? How are you going to continue using data to inform and improve your work? That is not clear to me.
Thank you. So moving on to our next set, which is trying to give a practical application of what we learned today. So I'll start by just giving a quick background on how the Youth Excel project was implemented. So, like we have indicated, we realized that mental health disorders were very high HIV. So we had a program that which is currently running funded by COVID relief. It's called Strong Minds, Strong Bodies. So the whole focus of that program is to integrate IPT into sport-based SRI. So we partnered with the local organization, Strong Minds Zambia, the expertise in IPT, and we came on board with our SRH concept and trained peer educators to be facilitators of mental health information and services away from the specialized. So we built the system at community level to ensure that these young people are able to screen through the PH9 and thereafter offer therapy. So what we realized, still discussions around mental health were being limited among them, were not extending to the community. And when a youth comes to our session at the facility, they'll talk about mental health, but when they go back home, they still get depressed when they're coming. So we said, okay, why don't we now get this supplementary resource, the magazine, which give to this young person, and we engage their whole family at household level, so that discussions on mental health are able to change community perspective rather than individual. Ensure, like you indicated, when I go back home, I should be able to, in an environment that supports my mental health. So the magazine, before the magazine was developed, we did an IRGPA. So we collected some context on literacy levels in Zambia, collected context on some of the issues affecting youths, collected information on some of the support systems we have. We went on and developed the magazine. The magazine was also developed using feedback from youths, feedback from stakeholders and parents from our formative research. Once that was done, we decided to target 2,500 youths living with HIV across 20 health facilities. So these are people that come to pick their medication for those engaging our program. So 2,500 copies printed, pre-tested. We got some feedback and made some modifications, and some of the feedback was add more cartoons because we had young people, our reach was from 10 to 24. So if we are going to keep it so content around written, leading to it. So we added some games, you can see there's a puzzle, and we tried by all means to bring in cartoons so that even that young person who comes to our program who's unable to read, at least they can read. So the first entry point before the magazine was beautiful. So when the magazine was developed, this peer educator, so these young people are seeing the yellow tissues. They actually sometimes called MTN because that's the color that MTN, our mobile network operator, uses. So they go to the communities and they build their capacity around how they can engage young people. So these peer educators went to the communities. They will first start by.
I think you are doing very well. 30 minutes warning, so 30 minutes to go. Thank you.
So, holding the young facility, identify all the young programs because magazine was a supplementary tool. We call the parents, get their consent, visit the home. The young peer educator would run through 3 sessions before and leave some homework. By the time I'm coming in, as a father, as a mother in this household, please engage this young person together with you. When they go again for the second visit was done virtually. So we wanted to reduce stress again. I think 6,500 again is 40 was a high now. So we tried to do virtual visits, but unfortunately in our rural sites, virtual visits were not possible because of connectivity challenges. Again, our IRGPA showed us that connectivity is an issue, but because the program was designed to have virtual visit, so we had to attempt the virtual visit in the urban. In the rural side, we went on to distribute. The third visit again, they will visit and now sit with the parents, understand how far you go. By the time all the 3 visits are completed, that young person would have become familiar. But not everything is perfect because we're not in a perfect role. We receive dropouts along the way where this young person moves to another village, they've gone to boarding schools, because the distribution was done during the holiday in some places. So we have to hold on until this young person comes back. In some cases, some parents were not willing because of the needs of mental health. And given that the magazine was being distributed to youth living with HIV, we had to make sure we work on the issue of stigmatization. So those are some of the challenges. First, we didn't want every young person to be into HIV positive. So at the end of the day, we will also, that's our video, and that's a young person sharing some of the findings. So when we completed our distribution, we have been sent this youngster household, they will go to the house. One of the young people that is engaged gave us consent. So based on what we did, we were able to reach close to 2,500 visas from this, but again, difficulty, because some geography, too rural distance. We had young people had to walk those long distances, even when we're providing funding that wasn't sufficient. So those are some of the young people telling us some of the common issues they faced in their community. So given that I've just given a brief background to our work, we would love to get your experiences. Given the work that you're working with young people, the magazine, and youth living with HIV, what would be, or what are you willing to adopt based on what the something that you can recommend to another partner in your implementation of your workers organization? So yes,
I think this is very lovely. But I think it's one of them that finds basketball learn more about it, see how we can be able to utilize this information and change it because our basketball environment is the same place in which our so they are people. So this is one of the things that
Thank you. So we are always open and share our contact. Even when it's soccer, it can still be getting in another thing because mental health doesn't distinguish. Any other what? Yes. Yes.
Was it online? Was it one-to-one?
So the virtual visits were done using mobile phone calls. So we had to set aside some stipend or some where we would buy talk time and call this young person. But again, that wasn't easy, right? Because sometimes non-response and sometimes connectivity issues. Even when we know that youths are very interested in mobile platforms or digital platforms, in urban area, in rural areas, especially. Yes. Yes, Mr. Golden.
This is where experience of feedback we are getting from reality when you give it all one-on-one.
Okay. So actually, we can even note that
future research whereby we try to understand what mode of delivery is most ideal for young people. Is it digital or maybe the in-person? But to respond to the weekend schedules, so our programs take two folds. There's one that is run through the working day from Monday to Friday. But for this specific program, we engage youth that are living with HIV on weekends. So we dedicate Saturday and Sunday for our programs. But with the magazine distribution, given the target that we had to use holidays if the kids were home to reach them during the working days. But it wasn't perfect because I'll go to the home and the parent who I need to talk to is not there. So in such instances, we had to revert. So in terms of the mobile application, again, like I've indicated, we haven't really explored which one works better, but from just some indication, we had seen that a young person is able to tell you that they have gone through the magazine if you are there to check. But if it's virtual, they can always tell you, yes, I've gone through. So I think to some extent, as we are pushing for digital engagement, we need to be careful. Sure. Thank you. I remember talking to Amy when she was telling me about the football concept, what you do now, how soccer comes in. Now, when you're doing it in field, you have, I think that's a good model for not only sports people, but also in school projects. Like for us now, we have so many school projects whereby we focus on club happening productions that are going on this week. So that's a good concept to it keeps the kids in they are well it's not a boring thing to talk about. They have a lot they're able to grasp and able to be able to see this for a long time. So it's appreciated what we're doing in terms of soccer, local in terms of so is it something you're willing to share with other partners? In fact, I was even told in here that I was hoping to share it because I was reading a lot of things. So sales and also the project that we are doing can now be able to expand them and make them more sustainable. I feel it's a good way of sustainability. Your ideas are good in terms of sustainability. All right, thank you.
Was it your just again? I think it's very innovative and understood. I think there's a lot of planning also. Just wanted to hear more about Hats doing the presentation about soccer and other games. Plus information just more than the us.
So she can actually give a demo of the rescue. Yeah. How it's done. Then maybe is there any question? Take on in terms of what you would like to adopt any addition?
I was adding on the magazine is nice, but I have been I'm co-authoring not a magazine, a comic book. And one thing that I have noted because we tried it online on Instagram and we shared, and the response was not really the same way you want to adapt it to local language. The youth for us know that we want to have English and a mixture of Kiswahili, which is called shells. And we have used two types of slides, and those ones worked so well. So as you think about, yes, it's important to use English, it's important to use the NGO language of some Adams, but how, if they're having fun, say, using Shell, at least also include maybe English, local language, and then the Shell that those people want, so that you don't ensure that most people dropping out. They feel comfortable and hard when you're also adapting to what they're.
So thank you. They don't know. I see PhD. That's the way you see them.
as practitioners using it, the guard, but also there are tools that are specific for like children and adolescents. They are also available. So you can also use them. I think what is important, I worked for World Vision in my initial years of work. We had a lot of art work going on. We had a lot also just hear and understand the colleagues who are at that level. That you're doing a lot of work, but you're not measuring them. So you can't market. You can't prove that what you are doing actually brings healing, improves well-being. Right? Yeah. So it is important because now where we are, the donors want evidence that what you are doing is giving some positive results. Even you will want, even each one of us will want some level of, evidence for everything that we do. Yeah. Chris, you want to throw some light? Okay. Every week we are meeting once for 90 minutes. So we do the rigorous dance. When we come in the group, we sit down, we do usual check-ins. For people who are psychologists, we do check-ins of how was the week, know what happened in the week, on the last time session, that problem. What is happening? Usually we have assignments, so we have things they need to practice and report on in the next week. So we do taking their home assignments. Then we go into the session of the day. The facilitator introduces today, we have an initiation, and this is what we do. Session. So when we close the session, then we jump in another meeting. How simple, so also the group are free to choose whatever dance. So we've seen the young people watching the modern music, which was very not in the dance. So now we buy small breakers that are chargeable. We give it to them. So in the sessions, they have that chargeable radios, have their music, and memory scanning, or if somebody's they took the music they want to use. Accept demonstration 7 and 8, where we are doing morning remembrance. So in our we have specific dance and specific songs for mourning our lost ones. So those are the only sessions where there is. They'll still have a choice of songs to choose from, but they have a limitation of dance. So they just do the funeral rites dance, which is classical dance. Yeah, but they have a variety of music to choose from for that. And then the last bit, of course, we are doing recognizing yourself, reconnecting back to yourself, reflecting about yourself, and then we do the stop start. What is it that I've learned in the 12 weeks that I need to stop doing? What is it that I need to stop? What is it that I need to start doing to keep my mental health well-being going well? Yeah, so then we give back to our communities. We do community awareness in our communities. Each group will task them to do at least 2, the ones that we can report on, and then the team.
Okay. Thank you.
There's a hand.
Okay.
Community groups, maybe if you're going to, like, maybe you are dealing with people, students from primary. Is that what you refer to some group or just maybe community?
Coach. Okay.
Yeah.
So when I say skills, do you say skills? Skills, yeah? Skills. Okay. So we're going to talk about avoid risk. We're going to talk about what? Avoid risk. I'm not getting to you. Not very loud. Avoid what?
Avoid risk.
So what is a risk? Risk is risky. Yes. Sessions, remember, we give phrases.
No wrong or right answer. So thank you very much. Who else can try? What is a risk? What is a risk? Guys, we've been having discussions. Yes. Bad thing. Huh? Bad thing. Bad thing? Bad thing? Okay. Anyone else? What is the risk? Where are you? Anything that can lead to harm. Eh? So how many people are? Okay, 3 people, right? So we'll give them the 3 kilo. The 3 kilo. The 3. So you say the 3 is also the kilo. The 3. So thank you very much. So what you've said, just to cement on what you've said, a risk is something that is bad, and I know there are quite a number of risks that we face as young people in our communities, right?
Yes.
So now we're going to talk about risks that are related to HIV. Risk related to what?
HIV.
What are some of the risks that are related to HIV? Forget about this. Forget about what you're saying. Forget about this. Just talk about the risks that you know. Then we'll have a discussion with this. What are some of the risks that you know?
Dying.
Huh?
Dying.
Dying? Okay. Dying, that's a good one. What are some of the risks that are presented in our community in line with HIV? Yes. Isolation by your community when you get HIV, right? Yeah. Thank you. What else? Stigmatization. Stigmatization. Nice. The guys, you're not seeing it. Yes. Infection. Okay. Excuse you. Excuse you. Nice. So now that you've said yes.
So when she says skills, skills is our language that we use to relate with young people. It's a motto. So when you say skills, it's meant to motivate.
And give your attention.
And we are telling you, there's nothing of the pictures. Yes,
Okay. Okay. So we said a risk is something that is bad, right? Are we together?
Yes.
What is the consequence? What is the consequence? Consequence? Yes.
Something that happens after you. An action, it's a reaction of an act, something that happens
after you do something. Okay. Consequence. Anything different here? The result of something else. So we're going to give them the 2 skill, right? The 2 skill. The 2. So now, what Rebecca is going to take you through what we call a risk field. So this is an activity we call risk field. We call it what? Risk field. Good. So in this risk field activity, we are going to talk about the kind of risks that an adolescent and a young person is faced in relation with HIV. In relation with what? HIV. So what is the easiest way to avoid risk related to having sex? What is the easiest way to avoid risk related to having sex? Yes?
Abstain.
Abstinence. Yes, that's not abstinence. Anyone else? Using protection.
Running away from girls.
Okay, so we're going to be concerned. So far, it's good. No, I want you to be in teams, 2 teams. So I want one line here and the other one. Please, let's be in teams. Let's be in line. Make a line, straight line. So, like, one more straight and the only hand up and then behind. So, yes.
This line has so many few people.
It's 25 per session. Because we want to make smaller groups interactive. 25
Okay. So we talked about the easiest ways to avoid risks, right? So we talked about abstinence, running off girls, speaking to one partner. Are you following team? Yes. Are you following team? So now, whether someone is living with HIV or not, what are some of the risk sexual behaviors that can spread HIV and STI? What are some of the risk behaviors that one can get HIV with guys. Yes?
Having sex without protection.
Having sex without protection, right? So the first one is what?
Unprotected sex.
Let's read it. Ninth one. Tell us. You can even do leakage here. Yes.
Injection sharing.
Injection sharing, right? Nice one. Anyone else? Yes. Having multiple partners, nice one. It's here, right? Yes. Anything else? As young people, we face these things, right? So anything else that you experience or anything else that you've noticed in our communities, what else? Apart from unprotected sex, multiple partners, anything else? Contact. Right? Okay. Anything else? Here. Anything else? Taking drugs, right? So there's sex and what? Alcohol. Are you with me, team? Yes. Yes, say yebo. Are you with me, team? Yebo. So now we are going to demonstrate. First, at individual level, when you dribble the ball, for example, I have the ball here. So when I say 1, 2, 3, go. So you dribble the ball like this, without hitting a cone. Just take your time.
Hello.
Then when you hit the cone,
Hello.
it will show you that
Hello.
you've done unprotected
Hello.
sex.
Could we kindly wind up in 3 minutes?
Thank you. So that's a
Yes, kindly wind up.
So can one demonstrate, then we wind up. One demonstrate so that to show that this is what goes on.
That is a player.
He's hit the cone, right?
Yes.
He's going to do the jump start. 1, 2, 3, go. 1, so you do 1, 2, 3, go. So go. 1, 2, 3. That is individual level, right?
Yes.
So him is going to face a lot of consequences. Remember, we're talking about the risk and the consequences. So when he has sex with, what is going to happen? He will get infected. The other thing, pregnancy. The other thing, everything, drop out of school, right? So this is how we use the soccer metaphor as we educate young people in our sessions. So because you've been a very wonderful group listening, we couldn't finish the whole session, I would like to thank you so very much. So there's a way in which we appreciate each other when we come to skills science. So imagine I've already done the attendance side. So thank you very much. So let's do a group cheer. Come. We will do a group cheer. So what positive word are we going to shout? What positive word are we going to shout today? And something about avoiding risk. So we are going to when I say 1, 2, 3, you say whoa. 1, 2, 3, whoa. Listen. The instructions. So the group cheer will be 1, 2, 3. You say whoa. 1, 2, 3. Whoa. 1, 2, 3. Avoid risk. Okay. Okay. Don't really.
Could we kindly come back to the main
1, 2, 3, go. 1, 2, 3.
activity?
Oh. 1, 2, 3.
Avoid risk. Could you kindly get your academic circle? We hope you have finished what you're doing. Maybe quickly, kindly head back to your seats right now. Kindly head back to your initial positions before the group work. Yes, we got the group feedback session.
Sorry.
I'm also going to the camera.
Okay. Hello. Okay, I think just remain where you are, but if you're showing me your back, kindly stand. Yes. If you're showing us your back, just stand. You are winding up like this. You guys can come and see. Hello. If you can hear me, kindly put up your right hand. If you can hear me, kindly put up your right hand. Your right hand. Your right hand.
Engagement.
Did the group hear me? Your right hand. You can hear me. Hello? Can you hear? Yes. Thank you so much for taking part in the group feedback activities. We would have loved for all of us get to know what every other organization is, but we are very still on time. So you can network and get contact of the different groups of people that you did have the opportunity to sit with, and then you can follow up this conversation beyond this conference, right? Because there's no one size fits all in the approaches you're going to use to implement the different ideas that you have. So can you speak to someone or ask someone to speak to you, whatever works, and then interact later on. Right about now, we would like to give a shout out to all the organizations that are represented here. We are winding down the day. So if you have your serious pen, you can put it away. We're getting to the briefing out part of the day. So like Wasani Sana to join me on stage as we applaud the groups of people that are here to just get to celebrate you. In case you did not know these people are here, you can now take this opportunity to say hi and network. Let me get my Immediately after the shout out, they will do a very brief 5-minute presentation that you can join in. After that, we will have Sylvia do the closing remark and invite our last guest. We hope to be gone by 4:30. If you're not gone by 4:30, at least 4:45. Okay? There's tea though. Are you ready for the shout out session? Okay. Ladies and gentlemen, help me celebrate Wasani Sana. Let's not overdo it, but it's because it's you. Okay, Grassroots Soccer Education Limited. So I think I missed out something. If you are from that organization, you can stand up and wave so that we know exactly who we are talking to. Sino? Is that okay? Yeah. Okay. Grassroots Soccer Education Limited. Where? Okay. Men's Health Foundation. The Youth Network. Generation Guidance CBO. So much. People, family, okay. Or I said the name wrong. Okay, maybe the same towers. Basic needs, basic rights, 10. I must say it's your Twitter. It's better than yours. Anyone who sees their Twitter? Okay, so coalition for preventive health. Okay. Health rights Kenya. Where are they? Okay, my bad. Since then, yeah. Youth Empowerment Training Network. Community Implementing Initiative. so much the Rock of Hope. Kenya Institute of Special Education. Thank you. Youth and Performing Arts. We petition to have a performance from Youth and Performing Arts. Okay, thank you. Youth and Success Association. ST Limited. ST Limited. Okay. Okay, cool. In absentia. Udi Kamau, he is a psychiatrist. Okay, thanks. We have the one and only Badili Africa. UNFPA. BHESP. On the left. Okay. UNDP. Okay. Thanks. UNICEF Kenya Country Board. USA. Okay. Iris. If you want an invite next time. Last but not least, Youth Alive Kenya. If I forgot the organization, you're allowed to find me. Super! Yay! Okay. Uh-huh. Oh, okay. Got yeah, diplomats for help. There's someone. Sorry? Lifeguard Kenya. There's someone from YSD Nairobi. I'll tell your boss. AMREF South Africa. Okay, so as the organizations are going to fight me outside, please fight me with. Kindly stand up. Her name is Esther Shiba. She sent me that list. So if you're fighting, you can give her more blows. Okay? Thanks. Yeah, very wise, yeah? So we're going to invite Wasani Sana to sing and dance with us in the next 5 minutes. At exactly 4:30, we'd like to invite Sylvia to do closing remarks. Okay? Aya, Wasani Sana. Say that.
We've been dancing here since morning and also doing choral verses while some of us enjoy, while some of us are watching. So at this moment, I will request each of us just to stand up Yeah, before the vote of thanks. Let's do this in the next 5 minutes. Not unless wezi kabisa. But if God bless you with 2 feet, kindly let's dance. You'll be following what they'll be doing. They'll be joining you people where you are. So. Good. We go. Aseko bayo tupoka yudo nyako machala chingiyu. Nya. Seko bayo topoka yudo nyako machala chingiyu. Nya. Chingiyu. In nyar siaya. Chingiyu. In nyar siaya. Nya. Achenyu, nimetembea sijamuona msichana kama chenyu. Nyagiravyo, nimetembea sijamuona msichana kama chenyu. Nyagiravyo. Achenyu, inya siaya nya ugenya. Achenyu. Achenyu. Bembe ae. Bembe ae, leo 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 bembe ae. Jojo. Leo bembe ae. Bembe ae. Bembe ae, bembe ae, leo bembe ae. 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 Jojo. Kata sali kata usiogope. Kata mwanamkata, kata usiogope. Kata sali kata usiogope. Kata mwanamkata, kata usiogope. Hey! Kibaba, kibaba. Penzwa kibaba, kibaba. Bedi yana ngombe, namini na ngombe sang. Namambia changaje, ataki, waidi na ila sang. Semeji yana ngombe, namini na ngombe. Namambia tuchanganye, ataki, waidi na ila sang. Semeji yana ngombe, mimi na ngombe zangu. Namambia tuchanganye. Zengeju ana ngombe, nami na ngombe zangu. Namwambia tuchanganye, hataki, kweli nenda zangu. Pembe ae, leo pembe ae. Pembe ae, leo pembe ae. Pembe ae, leo pembe ya mtoto. Pembe ae, leo pembe ae. Pembe ae, leo pembe ae. Bembe ae, leo bembe ya mtoto. Hebu wacha ukiwa. Bembe ya mtoto. Silie. Bembe ya mtoto. Uyo. Afi. Wachanua. Niwe. Wachanua. Ye baba. Kata mwanamkata, kata. Hata usiogope. Kata mwanamkata, kata. Tena usiogope.
Thank you so much. As Sylvia comes, we notice that there are groups of people that did not sign our registration form. Kindly see Esther Shiba. She's putting up her hand right now for registration purposes. And then help me welcome Sylvia. Sylvia. Oh.
Good evening, everyone. We have stayed on till the end. Clap for yourselves. Yeah. How was the event? I hope you enjoyed yourselves. I hope you learned something. Okay, good. So, we were gathered here to be able to get evidence on you getting data. So, we are very keen on data. And so, this is just me warming you up that please expect a survey. We're going to ask you a few questions about the summit, as well as some of what we didn't even get to discuss in the groups. We'd really like to keep on the conversations going. We want to work with as many partners as is possible. So please, when you get a survey from us, don't just send to spam or trash. Please do fill that survey. We want to be able to get your feedback, and we also want to see how we can move forward as a group with the different groups that are represented here. So I don't have that much to say. I think we have the MC did a wonderful job appreciating all the organizations that came here. There were also others that came and left, and we also appreciate their time with us today. So I just wanted to say a big shout out, a big thank you to all of us who are here today. So what's next steps now for us? I know that, as with every program, we have limited funding, limited scope in terms of what you can work with. But we do want to extend some support for mental health by continuing some of the work we've started with the partners. I hope that we'll be able to get more. A part of what you do requires stakeholder engagement. So I hope that through that, we'll be able to engage with a wide variety of stakeholders that are represented here. All these groups we've been clapping for. We hope that by one way or another, we are able to continue, to be able to continue the conversations we started today and start working together. So that is our hope. We have an open invite from the Ministry of Health. So I think that's also a place you can start and continue conversations as well. Maybe before I close, I also wanted to recognize the presence of Madam Bernadette Loloju. I think she's still here. Yes, there she is. Please wave and please clap for her. That is the CEO of the Anti-FGM board from the Ministry of Gender. So we are really grateful to have you with us. I don't want to ambush you. Otherwise, I'd have called you to come here and give some remarks, but we really appreciate your presence. And so in closing, I just want to say thank you to everyone who is here. We have appreciated your time. A lot of you have asked us as well. Okay. I've been told you got advance notice, so I'll be inviting you here shortly. But I just wanted to answer like some questions we've been getting. So one of them is, where is this information available? So we are going to be putting up all these, we call them knowledge products or public goods that you're seeing either, being hung here or you've been seeing them in terms of links. We are going to put all these knowledge products. There's a website run by USAID called Youth Lead. So if you just youthlead.org, Youth Excel has a page there where we put a lot of these. Remember, I talked about 100, public goods. So we have quite a number of them up there. So in addition to mental health, other sectoral focuses we've had, you can be able to access all that information there. In your booklets, I think all of you got a booklet that had the agenda and a little bit about the grant partners we had. There was also there a partnership document that talked about some of the ways in which you can work together. Please do have a look. And on my email is on that document. So you can just feel free to reach out and we can always see what are the possibilities when it comes to working together. So without further delay, since I'm told, Madam, you are briefed, I want to welcome you to just give us a few remarks as we close our event today. So please, a round of applause here as we welcome Madam Bernadette Loloju. Welcome.
I might get my leg broken with that height. Good evening, everyone. Yeah, thank you very much, Irex. My name is Bernadette Loloju. I'm the CEO of the Anti-FGM board. I'm very, very excited to be here and to see the work going on, a lot of work on issues of mental health and different areas that we can see to it that our young people are taken care of in terms of just checking out on them. I'm here on behalf of the Anti-FGM Board. I'm the sitting CEO now. The Anti-Female Genital Mutilation Board is a government agency under the Ministry of Public Service, Gender and Affirmative Action, and we are under the State Department for Gender. As we all know, we are within the 16 days of activism against gender-based violence, and a lot of violence is going on around us. And one of the worst forms of gender-based violence is female genital mutilation, and a lot of psychological stress and trauma that women who have undergone FGM go through. I'm a survivor, and so I understand what it means to go through FGM. I went through the cut when I was barely 13 years old. When I was growing up, FGM was fashionable. FGM was the way to go in my community. I thought that was the right thing for me. My parents thought that was the right thing for me. My grandmother celebrated. She felt that I've become a woman. And so I didn't understand. I thought maybe that's how every woman becomes a woman. But when I left my village, my small village in Rombo, and got a chance to go to Alliance Girls, that was my first time to leave my village. It was my first time to reach a school where I looked at all the girls in the eyes and I understood that to become a woman, I didn't need to go through FGM. But it was too late for me. Already I had gone through the cut. I had no reverse gear. There was no way I was going to turn the clock. And I had to live with that fact until today, when I'm a woman who is above 40 years old, and I still have to go through the pain and the trauma of really living with the scars. And that's why I'm here today, to really support Afia Africa, because they are doing a very good job in Narok of encouraging young women to say no to FGM and use their voices, working with survivors of FGM, young women who are going through the pain of something that they had never chosen to go through. We are dealing with issues of girls at the age of 6 months, 2 months, being taken through FGM, because now what is happening is that the parents are doing it early enough so that we don't get the time to talk to their girls, because now they know that we have the alternative rite of passage. We have the mentorship programs that we have at community level, and they know the moment the girls reach 9, 10, 11, 12 years, then they are aware that they can say no. So they are being cut at a younger age. So how do we go around this issue? How do we go around making sure that we have more girls who are safe from FGM? I'm happy to see my sister here from Isiolo, a survivor also, under the Women Rising Initiative. Women who are working so hard to bring the conversation into the family home so that women can protect their own daughters from FGM. So as the Anti-FGM Board, we are a government agency. Our role is more on mobilization of resources, policy and strategy. Our work is more on coordination to make sure that the FGM campaign in Kenya is more coordinated. And under my leadership, we have done a lot of work. We've been able to bring a lot of resources onto the table, and we are saying we need more money to go to the grassroots organizations, the ones that are where the rubber meets the road. We want more money to be put in the hands of the CBOs. And so I'm very happy today to say to it that most of the people in this room are having their own women-led, youth-led CBOs, men-led CBOs that are helping us to deal with all issues, not only FGM, because we've come to realize we cannot deal with FGM in a vacuum. We have to deal with it as a whole. Sexual and reproductive health. Teenage pregnancies is an issue. Narok is leading. You saw the number of girls who are doing exams pregnant. School dropouts. After they get pregnant, they drop out of school. Teenage, when they get married early, that's a lot of mental issues. Are the girls speaking to when they get pregnant? The other day I was in Marsabit. If you're from the Gabra community and you're a girl, if you get pregnant, they don't care whether you're raped or what happened to you. The community doesn't want to listen to you. You become an outcast. Immediately they realize you're pregnant and you're not married. So who is going to speak to these girls? Who are these girls going to speak to? Those are the questions I'm asking. Who are they going to? Who is the go-to person? When your own mother does not want you in the home, if your own father does not want you in the home, then who becomes the go-to person? And so a lot of questions. I want us in this room to really think about that girl That girl at the end of Marsabit, that Gabra girl who has no voice, it doesn't matter whether she was raped, nobody's going to listen to her. And she'll just become a statistics. The number of girls who are pregnant. Who made these girls pregnant? Where are the people who are making these girls pregnant? Why are we not getting hold of those people? Why are we not bringing the boy child into the conversation? Even if we talk to the girls and tell them don't get pregnant, who is making them pregnant? Why are we not talking to those who are making them pregnant? A girl can only be pregnant once in 9 months, but a man can make other women pregnant with those 9 months. So if I made a girl pregnant today, I can make another one tomorrow and another one next week and another one next month. So who are we dealing with? Are we dealing with the one bull that is going around making others pregnant? Or are we dealing with the one cow that only gets pregnant once in 9 months? And after that, it has to breastfeed. And after breastfeeding, it takes a bit of time before I become pregnant again. So that's what I'm saying. It's a cycle of about 15 months before I get pregnant again. So can we deal with the source of the pregnancy? Yeah. Let us talk to our community. Let us deal with the issues. Let us deal with the root cause of the problem. When it comes to FGM only happens in a household where the mother went through FGM. Because women who are seated in this room, who are 21%, in Kenya, according to the statistics of 2014, 21% of women in Kenya have gone through female genital mutilation. Meaning in this room, 21% of us are survivors of FGM. Because it's not even easy for you to stand in front of people and say, I went through the cut. But we are making it a conversation that it needs to be a normal conversation. If you're a Kisii woman, you're a Masai woman, you're a Gabra woman, you're a Borana woman, sitting here and you went through FGM, because the statistics have started getting the preliminary report of the KNPS, and I don't want to talk about it because it has not yet been released officially. We are getting the KDHS 2022 in the next 2 weeks, and they release the final report in March 2023. So that's when we will be confident enough to share the report. The report is not yet out. But what we are seeing is that FGM has calmed down. And what is making it calm down is because mothers like some of us who went through FGM when we were young have made a decision not to cut our own daughters. My daughter is 24, beautiful, educated, without the cut. And she will get married to the highest bidder in the land. Will not be brought 2 cows or 3 cows. Maybe they'll bring more, or they can take her without any bride price. But her herself, she is diamond. She is herself. She is, she is the best that the mother could produce. And that is why I want more mothers like me who have daughters and were taken through female genital mutilation when they were young, when they had no choice, and they took themselves because they thought it was the in thing. Some people took themselves thinking, because I don't want to be the one who will be the odd one out, let me take myself. Some people took themselves, and they took themselves not because they knew, but because out of ignorance. But today they know that they should not take their own daughters through FGM. So this morning I traveled all the way to Naivasha to speak to a group of young people, because I believe FGM will end in this generation. And after that, I said I have to come here because I always support my grassroots campaigners. And Afia Africa, Tito was on my neck. You have to come. And I had to travel again all the way from Naivasha to come and also say hi to you people. And thank you, my sister, because I got your email and I thought I would send a representative. But I said I still have to come, and I'm here. I was to travel this evening to Mombasa, and TFGM board has been nominated for the SDG Awards for the 3rd year running. We won in 2020, we won in 2021, and we are hoping to win in 2022 as the organization that is working with the grassroots and ending FGM in a generation. And I know we are going to do it, and we are going to make it, because the woman at the helm is a survivor. I know the pain. I know what it means to be a woman who has gone through the cut. And so I know what it means for no girl to be cut, because I am telling you, that place that is cut cannot be fixed. It can't. Kama mnasikianga watu wampata accident, sijui huku nyama ikatoka ingine ikatolewa hapa, huku hakuna mahali ya kutoa nyama. Madaktari wameshindwa watatoa wapi nyama. God created that place so special in a way that it cannot be fixed. it has to remain the way God created it. Haiwezi badilishwa. Na hapo ndio wanadamu wote wanapitia. Kuna mtu alipitia mahali ingine. Kama ulipitia CS, sawa, lakini kuingia uliingilia Kwa hivyo ukianza kuniambia eti tulifanyiwa CS, mimi nilitolewa na CS, na kuingia uliingilia na CS, uliingilia na wapi? So God created that place specifically, na iko na kazi yake, na inatakikana ichungwe kama chemichemi ya maji, isiwahi haribiwa. The way the Mau forest is being protected, the way the Abadeas forest is being, hata hiyo lazima Asanteni sana.
All right. Don't you think she deserves a better round of applause? I know I train a lot in sexual and reproductive health, but I've never thought you can talk about that place like that. So at least I've gotten tips for my next session. So thank you very much. And we are really glad that you joined us today. So as we wind up, first, I know everyone else has been appreciated, but allow me to appreciate Michelle and David. I think they did a very good job. So let them stand. Let them stand. We'll appreciate them in a special way. So let them stand. I know they promised that they will keep us energized, they will keep us engaged. Have they delivered? Yes, so they're not like some of our politicians, they didn't deliver, they delivered. So we have to appreciate them in a very special way, okay? So I call this the abstinence clap, because I do a lot of SRH. So why I call it the abstinence clap is because the first 2 times we will not clap, but the third time we'll give them a big clap, okay? So when I say 1, you do, you are abstaining. Okay, and then when I say 2, you abstain. Then the third time we engage. Okay, so are we ready? So 1 time we abstain, 1, abstain, 2, abstain, 3, engage. Awesome. So thank you very much, David and Michelle, for a job well done. I'm really, really happy, by the way. Looking forward to work with you again. So for our grantees, as the people exit, we'll see you guys for about 5 minutes, and then we call it a day. And to everyone else, thank you for coming. Imagine if you were not here, this event would not have been a success. Cinder. So thank you from the bottom of our hearts for coming. Some of us were not sleeping because we were really like, will those people come? You know, Youth Alive will tell you from the many meetings we've done, we're asking ourselves, we have sent invitations. Some people did not confirm, but we're asking, are you guys going to come? So for you guys coming, I think for us, is a big, big success. Even those who confirmed in the morning and they still came. So thank you very much. Sawa. So Devi and Michelle, do you want to come and wind it up for us in a special way? I don't know whether you guys have something, but you just come and wind up. You are the MCs. Go come and close the event. So thank you, everyone.
So, Michelle, I think it was all about the game of numbers. And as people are living, we might teach them how to count with their own bodies, because it is also a way of making sure that you are refreshed in your body, okay? So kindly stand up.
I failed math.
Yeah? You failed math. No, this one is not hard. Just come up here. So each and every person just stand up. This is very simple. Even as you go home, it will help you when you feel like you have a lot. It will help you to refresh. So this is how you count with your body. Yeah? This is 1. Find space, space up, space up, space up, space up, space up. So this is how we are winding up. So this is 1. 1. This is 2. Is this 2? Seriously. So this is 1 plus 1. You turn equal 2. You go change that one. So 1 equals 2. Okay? So in that position, 2 equals 4. Okay? In that position, 4 plus 4 equals 8. 8 plus 8 equals 1 plus 6.
Wait.
We do it faster. We do it faster and then we finish.
Okay, me, I will say the words to the mic. Okay. 1 equals 2. 2 plus 2 equals 4. 4 plus 4 equals 8. 8 plus 8 equals 16. Thank you so much, MC Kim. So, as we wind up, Akimia had said my last remarks. But there's one resource that we might need to ask ourselves, how did we use it? Did you guys notice we had a DJ? Imagine we have a DJ. So, DJ, please take us, I don't know, Eswatini, and then Zambia, and then Uganda, and then we finish in Kenya.
Yeah, sure.
Or we start in Kenya and manifest the last song is the last place we will go. Okay, you want to live and die in Kenya, not even Africa. Okay, DJ, take us away. Have fun, guys. Oh, and there's tea. And if you hadn't registered, please see my girl, Esther. Yes, okay, let's go, DJ.
Sawa, DJ. So you can still network. This is also an opportunity to network. If you haven't talked to somebody, talk to them. Ask for their numbers as you plan to leave.
You know, where I be, there are kings and queens in these streets. The mummies, it's like they come from my dreams. I gotta be